Duplicate screen. Duplicate screen പറഞ്ഞെന്തോ കൊടുക്കണ്ടേ അല്ലായിരുന്നു? ഡ്യൂപ്ലിക്കേറ്റ് വരുന്നില്ല. സൂം ചെയ്യണ്ടോ? Sir? Topic in the shall I start? This is a poster on primary extranodal marginal zone B-cell lymphoma of the urinary bladder coexisting with malakoplakia, a case study. Now, we know that primary lymphoma of the urinary bladder is very rare, constituting about less than 1%. And the most common subtype is the extranodal marginal zone B-cell lymphoma of the MAL type. Malakoplakia is a chronic inflammatory condition that can coexist, which further complicates the diagnosis. In this situation, PET-CT may be misleading because of the neoplastic as well as the inflammatory component, making distinguishing difficult. The aim of this is to present an unusual case of primary extranodal marginal zone lymphoma of the urinary bladder, mimicking a urothelial carcinoma, and this case is complicated by the coexisting malakoplakia. Here I present a 47-year-old female presenting with history of hematuria. She was evaluated in the urology department, and radiologically there was a conglomerate intraluminal polypoidal mass in the urinary bladder in the anterior as well as the lateral wall, around 12 into 3.5 into 8.8 centimeter, which was involving the muscle, and there was minimal extravesical invasion, which mimicked the stage T2B or T3 bladder cancer. A baseline PET-CT was taken, which show an FDG-avid lesion with an SUV max of 17.2 in the urinary bladder with the same extension and size. There was no FDG-avid nodal or other metastasis. With this finding, the urology department went ahead with the cystoscopy, confirmed the finding, and a biopsy was taken from the lesion. The HPR showed atypical B-cell lymphocytes, and on histochemistry, they showed CD19, CD20, and BCL2 positivity, and this confirmed the presence of low-grade lymphoma. And there was also they also ran a special staining with pearls and von Cosa, which showed Michaelis Guttman bodies, and with this they confirmed diagnosis of low-grade marginal zone lymphoma with coexisting malakoplakia. And this is the appearance of the pre-treatment PET scan, which showed very high uptake in the order of 17.2, involving the anterior and the lateral wall, all pretty big lesion in the size of 12 into 3.5 into 8 centimeter. So, with the diagnosis of low-grade marginal zone lymphoma, in spite of high PET-CT, which might be attributed to the coexisting malakoplakia, a diagnosis of lymphoma was made, and patient was treated with 6 cycles of R-CHOP chemotherapy, followed by radical radiotherapy to a dose of 36 gray in 18 fraction. After 6 cycle, we ran a PET CT, which showed partial response. And the post-treatment PET CT was taken 1 month after treatment, which showed complete metabolic response. And after 6 months, she was followed up with a cystoscopy, which showed a normal bladder mucosa. So this is the treatment field. Patient was treated by box technique using 4 field, and PT was given a 95% dose. So this presentation is made to highlight the importance of diagnosing primary bladder marginal zone lymphoma, which can mimic urothelial carcinoma both radiologically and metabolically, and coexisting malakoplakia probably was the reason for the high FDG uptake. This complicated our diagnosis, but in this situation, histology along with IHC remain the gold standard. And we all know that combined R-CHOP and consolidation radiotherapy is highly effective for bulky disease, and she attained cured with our treatment. Thank you. Yes, sir. Here, this was a low-grade NHL. So, usually in a low-grade NHL, we assume a slightly low FTG uptake. But this FTG uptake of 17 probably made us think that it was a carcinoma of the bladder. But because of the histology, when the histology came as low-grade, again we were confused because there was low-grade tumor with a high uptake. So, probably it was this coexisting inflammation which brought about this high SUV.
Okay. Did you do any literature review?
Yes, sir.
What is it?
Sir, this case was reported only in less than 1%, and most common histology was the marginal zone type, B cell type, and patient were treated with either with chemotherapy alone or because
it's a low-grade lymphoma, isn't it?
Yes, yes.
So what is the indication for chemo?
Because it is an extranodal lymphoma, most of these patients were given 6 cycles of chemotherapy. Okay. And since this patient had a bulky disease, we gave. Sir?
Because of the large tumor you might have taken.
Yes, sir. So large size. Initially, the size of the tumor was 12 point something, in the order of 12 point something. So we gave a chemotherapy, and in spite of the response, because it was a bulky tumor, we wanted to consolidate.
No, make an indication. Why can't you do a localized treatment?
Radiotherapy, yes. Radiotherapy would have been sufficient, but because of the large bulk of the tumor, we thought of giving chemotherapy.
Okay.
Okay, thank you, sir.
Thank you, Dr. Shruti. I request the candidates to please adhere to the given time limit. The next candidate is Dr. Risha Luluke.
Good morning, all. I'm going to be Good morning all. I'm going to be presenting my poster titled When Thirst Tells a Tumor's Tale, a Pediatric Supracellular Mixed Germ Cell Tumor with Central Diabetes Insipidus. So intracranial germ cell tumors are rare pediatric neoplasms and they comprise of only less than 2% of pediatric CNS neoplasms. They most commonly arise from pineal and supracellular regions. Also, they most commonly present as with features of increased ICP or central diabetes insipidus, or they can also present with decreased visual acuity or bitemporal hemianopia. Here my aim is to describe a rare pediatric supracellular mixed germ cell tumor presenting with central diabetes insipidus and to discuss its diagnostic challenges and multimodality management. So my case is a 6-year-old female child. She was presented with excessive thirst, increased urination, weight loss and vomiting. So a comprehensive neurological examination and endocrine assessment was undertaken. She was found to be malnourished and stunted. On laboratory investigation, she had hypernatremia with decreased urine osmolality, pointing towards diabetes insipidus. And on further endocrine assessment, she was found to have hypocortisolism, also hypothyroidism. So we did, an MRI brain was done, which showed a well-defined, smoothly marginated focal lesion measuring about 5.5 centimeter in maximum diameter. A whole spine screening was also done, which showed no CSF dissemination. A serum markers were done initially, which showed both AFB and HCG elevated. And she underwent a right pterional craniotomy with surgical biopsy, which came as mixed germ cell tumor with predominant yolk sac component, and IHC was AFP and SAL4 positive. She was presented to our institute after this biopsy, and after a multidisciplinary tumor board discussion from our side, it was decided to give chemo to the child. And 6 cycles of platinum-based chemo was planned from pediatric oncology side. Alternative carboplatin etoposide and ifosfamide etoposide chemo was taken, but due to poor tolerance and treatment-related toxicity, instead of the planned 6 cycles of chemo, she could only receive 4 cycles. And after 4 cycles of chemo, we did a post-chemo MRI brain, which showed a residual lesion, approximately 2.4 centimeter in maximum diameter. Post-chemotherapy MRI demonstrated approximately 90 to 95% reduction in tumor volume. Again, after a multidisciplinary tumor board discussion, since ideally we could have gone for a resection, but since it was unresectable, deemed unresectable by neurosurgery, since it was very close to critical structures, we did a radiotherapy, a whole ventricular irradiation of 24 gray in 12 fraction, followed by a boost of 30 gray in 15 fraction. A total dose of 54 gray was delivered. You can see the PTV images below. And on a 6-week follow-up, the MRI demonstrated near complete radiological response, and serum AFB had a marked reduction approaching normal range. So I would like to conclude by saying that persistent central diabetes insipidus may be the first warning sign of supracellular malignancy. Mixed germ cell tumors with non-germinomatous elements should be aggressively treated, and this case especially highlights how coordinated surgical, chemotherapeutic and radiation strategies can achieve near complete radiological response despite chemotherapy intolerance. Thank you. We haven't checked. Yes, sir, there was already a residual lesion, but AFP is not available. Nice.
Okay.
Thank you.
Thank you, Dr. Risha. The next presentation is by Dr. Karthik S.
Good morning, everyone. I'm here to present a case report of metastatic renal cell carcinoma presenting as a thyroglossal duct cyst, a rare diagnostic entity. Thyroglossal duct cysts are most common congenital midline neck masses. The malignancy is very rare, comprised of less than 1% and usually represents papillary thyroid carcinoma. The metastatic involvement of a thyroglossal duct cyst from distant primary is exceedingly rare, and the renal cell carcinoma is known for late and atypical metastasis. We report a case of metastatic clear cell renal cell carcinoma presenting as a thyroglossal duct cyst. We have a patient, 60-year-old female, presented with 8-month history of painless midline neck swelling, moving with deglutition and tongue protrusion, and without any compressive or constitutional symptoms. Past history, patient as a known case of a right renal cell carcinoma, clear cell, grade 1, treated with radical nephrectomy in 2020, and stage 2, PT2B N0, and underwent total thyroidectomy for midline neck swelling in August 2024 for follicular nodular disease. On examination, patient having midline infrared swelling with no cervical lymphadenopathy. On investigations with ultrasound shows 1.5 cross 1.3 centimeter, predominantly solid infrared midline lesion, thyroglossal duct cyst versus FNSC from the neck swelling came out as suggestive of a few atypical cells. The patient underwent cyst-tongue procedure, and histopathology shows papillary architecture with a clear cell and IHC suggestive of a PAX8, CAIX positive, AMACR positive, and CK7, CK20, TTF1 thyroglobulin were negative, confirming case with metastatic clear cell renal cell carcinoma involving thyroglossal duct cyst. And after staging workup, patient have no evidence of any distal mets, and after MDT discussion, patient was treated as a case of oligometastatic renal cell carcinoma, and patient was started on tab lenvatinib, and patient was now doing well. Discussion, primary thyroglossal duct cyst malignancy are very rare, and metastasis from the distant primary is exceptional. The renal cell carcinoma exhibits unpredictable metastatic behavior and may present years after definitive treatment at unusual sites. Distinguishing from primary thyroglossal duct cyst carcinoma from the metastasis is crucial due to therapeutic implications. The PAX8 and CAIX positive with the thyroid marker negative confirms the renal origin. Surgical excision is a diagnostic, while systemic targeted therapy is cornerstone of the management. On conclusion, metastatic RCC to thyroglossal duct cyst is extremely rare, and atypical thyroglossal duct cyst warrants evaluation for metastasis, especially with prior history of malignancy. The IHC is always essential for identifying the primary site, and multidisciplinary tumor discussion is always critical. Thank you.
What's the role of lenvatinib when you remove the metastasis? Only one mets was that you are removing. There are no other mets.
Since patient have oligometastatic, it is a systemic spread. Yes, sir, almost 4 years.
And you have not done a PET scan.
We have done, patient was not affordable with the PET CT, so we have done with the CECT thorax, abdomen and pelvis, sir.
What about the bones?
You have not done, sir.
Because renal cell carcinoma, you can get bone mets, isn't it?
Yes, sir.
Bone scan was not taken.
Not done, sir.
Like an indication for lenvatinib questionable.
Systemic spread.
No, there is no systemic spread now. Is there any role for adjuvant treatment in? You said that it's an oligometastatic disease.
Yes, sir.
Is there any role for immunotherapy?
Yes, sir. Temporal.
Okay. Okay, thank you.
Thank you.
Thank you, Dr. Karthik. The next poster will be presented by Dr. Alicia Maria.
Ma'am.
Good morning, everyone. I'm Dr. Alicia Maria Benny. So today I'll be presenting a case of paraneoplastic inflammatory myositis in a patient with breast carcinoma. So paraneoplastic inflammatory myositis is an uncommon immune-mediated manifestation of malignancy and is rarely associated with breast carcinoma in approximately less than 1% of cases. It typically presents with proximal muscle weakness and elevated muscle enzymes occurring independent of tumor invasion or treatment toxicity. The diagnostic differentiation is a challenging part due to its overlap with metastatic disease, therapy-related myopathy, and primary autoimmune conditions. So we present a rare case of carcinoma breast associated with paraneoplastic inflammatory myositis. So this patient is a 63-year-old female, known case of CAD ACS NSTEMI, diabetes mellitus, presented with progressive bilateral lower limb weakness for 8 months and bilateral upper limb weakness for 1 month. Patient also had right breast lump for 6 months with which he ignored, and patient was on alternate treatment for weakness. On presentation, power was 0/5 in bilateral hip, 2/5 in bilateral knee shoulder, and 3/5 in bilateral ankle elbow, and 4/5 in bilateral wrist. And on examination, right breast, there was a 5 into 4.5 centimeter hard lump in retroareolar region and 2 into 2.5 centimeter hard lymph node in right axilla. CT brain was done, which showed no significant findings, and CCT thorax was done, which showed right breast soft tissue lesion with multiple enlarged right axillary lymph nodes and a hypoenhancing subscapular lesion in segment 4B of liver, 1.4 into 1.3 centimeter, suggestive of liver metastasis. FNAC was done from right breast lump, suggestive of IAC Yokohama grade 5 malignant, and true cut biopsy from right breast lump showed invasive carcinoma breast NST MBR grade 2, ERPR positive, HER2 positive, and Ka67 20%. Patient was further done MRI whole spine screening, which showed symmetric hypointensity in bilateral paraspinal and proximal girdle muscles with focal fatty atrophy and enhancement, consistent with inflammatory myositis, along with edema and enhancement, likely representing active disease process. The muscle enzyme markers like CKMB was elevated 176 and LDH was elevated 605. We did serum myositis profile, which showed positive anti-SRP and anti-Rho52. After tumor board discussion, patient was treated as case of metastatic CA breast C T2N1M1 with paraneoplastic inflammatory myositis, and patient was started on tab letrozole and monthly injection methylprednisolone and injection rituximab. Injection trastuzumab was deferred in view of cardiac comorbidity. Following the initiation of treatment, muscle power improved and breast lump regressed by 2 months. At 1.5 years follow-up, muscle power was 3/5 in bilateral hip, 4/5 bilateral knee and shoulder, 5/5 in bilateral elbow, wrist, and there was no palpable breast lump and axillary lymph node. Reassessment with CCT abdomen showed a stable liver lesion. Now patient is able to walk with minimal support. So discussion. Paraneoplastic inflammatory myositis is a rare immune-mediated manifestation that can mimic metastatic or primary autoimmune muscle disease in breast cancer. In this case, anti-SRP and anti-Rho52 positivity with MRI confirmed myositis supported an immune-mediated rather than metastatic process, and the improvement in muscle strength and tumor burden following therapy favors a paraneoplastic etiology. So to conclude, paraneoplastic inflammatory myositis, though rare in breast carcinoma, should be considered in patients presenting with unexplained progressive muscle weakness, and a multidisciplinary approach integrating clinical, serological, and radiological findings is essential for accurate diagnosis. The early recognition and combined oncologic and immunosuppressive therapy can lead to meaningful functional improvement and disease control. Thank you.
Is there any role for muscle biopsy?
There is actually a role for muscle biopsy to differentiate the idiopathic myositis, but in this case, the immune myositis panel was pointing towards paraneoplastic myositis, and patient was not willing for muscle biopsy, because of which we proceeded with the impression of paraneoplastic myositis.
Okay. Okay, thank you.
May I invite Dr. Juhi Priyavadivel for the next presentation.
Good morning, everyone. I am Dr. Juhi Priya. I am here to present a case on primary neuroectodermal tumor of the kidney, a rare clinical entity managed with intensive multimodal therapy. So, primary renal primitive neuroectodermal tumor is a very exceedingly rare and a high-grade malignancy with fewer than 200 cases reported worldwide. Due to its aggressive behavior and histological overlap with other small round blue cell tumors, molecular confirmation is considered the diagnostic gold standard. The aggressive multimodality treatment is recommended for the management of these tumors. So, our aim is to look into the intensive multimodal therapy. This is a 22-year-old male who is just a freshly graduated nursing student, was evaluated for a large left renal mass measuring 8.7 into 7.2 centimeter with renal vein involvement, and he underwent radical nephrectomy. Histological examination revealed a small round ovoid cell tumor, and IHCs were positive for CD99 and FLI1. Molecular confirmation was done using next generation sequencing, which identify EWSR1 and FLI1 fusion. So the demographic data of this is that it is a very extremely rare and a highly aggressive malignancy of neural crest origin with incidence less than 1%. And the age distribution is, it predominantly affects adolescents and young adults with a median age of 27.5. In our case, the patient is 22. So a 22-year-old male was first evaluated for a left-sided flank pain of 2 weeks duration, and his performance status was 1. The imaging showed imaging CT abdomen and pelvis was done, which showed a well-defined exophytic heterogeneous mass measuring 8.6 into 6.6 into 6.5 centimeter, arising from the mid and lower pole of left kidney. And it is noted infiltrating the left renal vein and with paraaortic lymphadenopathy. MRI showed a renal malignant mass lesion extending to renal vein and no IVC involvement observed. Chest X-ray was done, which showed no significant findings, and the patient underwent left radical nephrectomy. Post which the histopathological findings were grossly the tumor size measured 8.1 into 5.6 into 5 centimeter with infiltration into the renal pelvis, sinus, capsule and the perinephric fat. And the IHC was FLI1 strong positive with Ki 67, 70 to 80% and negative for LCA and chromogranin. A next generation sequencing was done to confirm it, which showed positive for EWSR1 and FL1 fusion. And it was diagnosed as primitive neuroectodermal tumor of the left kidney. But the disease course, the post-op PET CT, which was taken exactly 1 month after which, showed a disease recurrence with uptake in the left nephrectomy bed, splenic hilar region and peritoneum, and largest conglomerate mass measuring 8 into 6.1 centimeter with mesenteric deposits, and multiple variably sized bilateral lung nodules. So the current management is, we have planned for a chemotherapy with VAC-IE regimen followed by consolidative radiotherapy. He has successfully completed 4 cycles of chemotherapy and has tolerated it very well. Primary renal peanut is a rare and aggressive malignancy requiring high index of suspicion. This case highlights the critical role of NGS in establishing definitive diagnosis and guiding therapy with aggressive multimodal management with prolonged systemic chemotherapy and consolidative radiotherapy, which remains essential for achieving optimal local and systemic disease control in young patients. I thank Dr. Ashwin Kumar, Professor, Regional Cancer Center, Trivandrum, and Department of Radiation Oncology.
Your radical nephrectomy, what about the lymph nodal status?
Post-radical nephrectomy.
They have removed the lymph nodes also. Is it involved or not? That was positive.
The lymph nodes were
Positive. Then you didn't start chemotherapy immediately.
The thing is, the left radical nephrectomy was done outside, sir. The patient came with the post-op PET CT to RCC. So we immediately started on chemotherapy.
So there was no staging workup done before surgery.
Yes, sir. They only did the CT abdomen and pelvis. And
So that part is not clear in your presentation.
If the only a chest X-ray was done initially, and only a chest X-ray was done initially, and they have not evaluated the chest, sir.
And you have mixed up the methodology and results. So all these things should come in the methodology, workup and other things.
Okay, sir.
Any more? Okay, thank you.
Thank you, sir.
Next, Dr. Darshan.
Yeah. Yeah.
Oh, okay. Good morning, everyone. My study is on short-term clinical outcomes of patient with locally advanced adenocarcinoma rectum, a prospective observational study. Coming to the introduction, colorectal cancer is third common in incidence and second leading cause of cancer-related mortality according to Globocon 2022 data. Current neoadjuvant options include long-course chemo-RT, short-course RT, and total neoadjuvant therapy. These treatment regimens have demonstrated effectiveness in improving local control and pathological response, but data on treatment-related acute toxicity and tumor response across these approaches remain limited, particularly in Indian population. So the aim of our study is to assess the short-term clinical outcomes of patients with locally advanced adenocarcinoma rectum treated with various neoadjuvant therapies. It is a prospective observational study conducted at RCC Trivandrum. We enrolled 94 patients meeting the eligibility criteria. Neoadjuvant treatment protocols are long-course chemo-RT, which was delivered as 45 to 50.4 grain, 25 to 28 fraction, along with concurrent capecitabine, followed by surgery. Short-course RT is delivered as 25 grain, 5 fraction, followed by delayed surgery. TNT is delivered as Capox or Folfox-based regimen, either given as induction and or consolidation, along with short-course RT or long-course RT, followed by surgery. Acute toxicity assessment was done using CTCAE version 5. Pathological assessment was done using modified Ryan's grading, and MRTRG assessment was done using and MRI assessment was done using MRTRG grading. Coming to the patient demographics, the median age was 61 years, ECOG performance status 1 being more common in 73.4%, the most common site of tumor being lower rectum in 57.4%, the most common histology being moderately differentiated adenocarcinoma in 81.9%, and the most common stage being 96.8%. Stage 3. 64 patients, 68.1% received long course RT, 25 patients, 26.6% received TNT, and 5 patients, 5.3% received short course RT. Coming to the results, chemotherapy related toxicity, 56% in long course RT and 16% in the TNT remain toxicity free, while 6.3% in the long course RT and 28% in the TNT had grade 3 or more adverse events. Coming to TNT specific toxicity, neutropenia was most commonly observed. Any grade neutropenia was 64%, while grade 3 or more was seen in 24%. Other side effects included hand-foot syndrome, diarrhea, thrombocytopenia, gastritis and neuropathy, all being grade 1 and 2 except for diarrhea. Diarrhea was seen in 4% of the patients. Coming to acute radiation related toxicity, all the patients in short course RT remained acute toxicity free, and 29.7% in long course RT had no toxicity and 56% in TNT had no toxicity. Coming to grade 3 or more events, 9.4% in long course RT had grade 3 or more toxicity and 4% in TNT had grade 3 or more toxicity. Coming to RT toxicity by type, in GI toxicity was most commonly observed, which was 43.8 in long course RT and 32% in the TNT. Radiation dermatitis was seen in 31.2% in long course RT and 20% in TNT. Other side effects including dysuria, pain was seen in 42.2% in long course RT and 16% in TNT. Coming to MRTRG response assessment, MRTRG 1 was seen in 10.7% in long course RT and 40% in short course RT. MRTRG 2 was seen in 39.3% in long course, 45.8 in TNT and 20% in short course. And MRTRG 3 was 35.7 in long course, 37.5 in TNT and 20% in short course. Coming to overall MRTRG grading, MRTRG 1 was in 9.4, 2 in 40%, 3 in 35.3% and 4 in 14.1% and 5 in 1.2%. Coming to pathological response by group, all the regimens are equally comparable pathological complete response, which was 21.2 in long course, 21.7 in TNT and 20% in short course. Modified Ryan score 2 partial response was the most common, seen in 53.8 in long course, 69.6 in TNT and 40% in short course. Coming to overall modified Ryan's grading, PCR was seen in 21.5% and near complete was seen in 8.9, score 2 in 58.2 and score 3 in 11.4. All the operated patients are 100% R0 resection, meaning that all the regimens are rated equally in tumor downstaging, and the PCR rate was comparable among all the regimens, which was 21.5%. And we also done an additional assessment for comparing MRTRG with pathological correlation, which showed 87% sensitivity for MRTRG, which means MRTRG has a 87% positive predictive value, but the specificity is only 11%, which has a negative predictive value. Conclusion: a neoadjuvant treatment is comparable in tumor downstaging, R0 resection, and satisfactory clinical and pathological response. Thank you.
Darshan, when you present such a large study, you can fragment it and give one point and finish it quickly. That's a better option rather than presenting all the outcome together. It's a good study.
What is the definition of a short-term outcome? When did you assess the outcomes? At what point of time? It is not mentioned in the methodology.
Yes, sir. By short-term clinical outcomes, I mean we meant that acute treatment-related toxicities and the pathological and clinical responses we meant, sir. After completion of neoadjuvant treatment, the patient underwent MRI response assessment, which was clinical response assessment.
The time period. At what point of time?
1 month after completion of neoadjuvant treatment.
What about the short term and long term radiation?
In long course RT and
Yes.
Sorry.
No, because your assessment is very important. The time point is very important.
Yes, sir.
So when did you assess all these things? That's my question.
Sir, MRI assessment was done after 1 month of completing the neoadjuvant treatment regimen, sir.
Neoadjuvant treatment.
Yes, sir. And after that,
But
after,
it's not mentioned in the methodology. Can you show the methodology? No, where is the methodology?
so this is method.
Okay. Time period is not. Is it mentioned? No.
No, sir. Time period is mentioned only for acute toxicity. Only for acute toxicity, I mentioned it as weekly assessment.
That is weekly assessment.
For radiological assessment, it has been done after 1 month of completing neoadjuvant treatment, sir.
Where is your result heading?
Okay.
Result.
Oh, I need.
Is it? It comes under methodology, isn't it? No.
No, sir. Demographic and baseline.
Where is the result? No, there are certain headings in
Yes,
when you present it. Introduction, methodology, results, discussion, and conclusion. So my question is, where is the result? Heading. Illa.
So, sir is asking us results.
It comes.
I understand, sir. I missed it out.
Thank you.
Thank you.
Thank you. Next, may I invite Dr. Femi Matthew for the presentation.
Good morning everyone. I am presenting a case of sinonasal angiosarcoma treated with excision and radiation. Coming to introduction, angiosarcoma is a rare malignant tumor accounting for about 1% of sarcomas, and the sinonasal site is exceptional. Risk factors are telangiectasia, trauma and chronic edema. Clinically, patient may present with unilateral rhinological syndromes, and at the more advanced stages, patient may present with invasion of vital structures. On imaging, there will be a heterogeneous contrast enhancement with sign of bone destruction. IHC is done to confirm the diagnosis, which shows positivity for factor 8, CD31 and CD34. Treatment is usually surgery followed by radiation. Other treatment modalities are chemo, radiosurgery and interleukins. However, no standardized therapeutic management has been defined. Aim of the study to present a rare case of sinonasal angiosarcoma and to highlight its clinical presentation, diagnostic challenges, histopathologic features and multidisciplinary management approach. A 50-year-old 50-year-old hypertensive female presented with epistaxis, and ENT evaluation showed an encapsulated reddish black bleeding mass in the left nasal cavity lying medial to middle turbinate. CTPNS showed a lesion filling posterior of left nasal cavity bulging into nasopharynx, extending, filling and eroding ethmoidal ASLs, and initial biopsy came as vascular neoplasm with bone infiltration with Ka67 of 25%, CD34, BCL2 and CD99 positivity. Thorax was evaluated and within normal limit. In view of recurrent symptoms, patient underwent endoscopic nasal mass excision and it showed a smooth mass lateral to middle turbinate, and the lesion was excised in peace. HPR showed a stratified squamous epithelium with arborizing vascular channels suggestive of sinonasal angiosarcoma. She was given adjuvant RT of 60/30 fraction and the treatment completed on March 2025. Patient post-treatment CT-PNS neck was evaluated and ENT evaluation was within normal limit. Patient is kept under close follow-up with routine imaging and ENT reviews. Conclusion, sinonasal angiosarcoma is a rare aggressive vascular malignancy with high tendency of local recurrence. Complete surgical excision followed by adjuvant RT is essential for local control. Distant metastasis occur to bone, lungs, liver or skin or cervix. 5-year survival rate is 22%. Prognostic factors are early diagnosis, grade, age, size and resectability. Owing to its aggressive nature, vigilant long-term follow-up is mandatory. Thank you.
What are the risk factors? Is telangiectasia a risk factor?
Telangiectasia, trauma, chronic edema.
Is it going like that? Okay, what was the status of the surgery? Is it just a biopsy or?
Initially biopsy was done and later endoscopic nasal mass excision was done with complete excision in a piece with no break.
Okay. It was not an R0, it just must be.
It was.
Okay. And what is the staging workup done? Only thorax was evaluated or the?
CT thorax, CT PNS and neck was evaluated. Abdomen was not evaluated.
No, you said that there are some
Chance of
recurrence. Metastatic this thing is high, isn't it?
It was not evaluated.
Okay. Okay, thank you.
Thank you, sir.
Hello. Next, Dr. Midhu Varshan will be presenting.
Good morning all. Today I am going to present a case of rare supratentorial ependymoma in a child. So ependymoma is a primary central nervous system tumor arises from ependymal cells lining ventricular system and central canal of spinal cord. It is considered a rare tumor with annual incidence of 0.2 to 0.4 per 1 lakh population. In children, the most common site is posterior fossa, particularly arising from flora fourth ventricle. Here, supratentorial ependymoma is a grade 3 is a rare malignant glial tumor arising from ependymal cells in the cerebral hemisphere. So, A 10-year-old boy presented with 1 month history of headache, nausea, fever, and seizure. On examination, is conscious oriented, no sensory motor deficit. So brain MRI showed extraaxial esvolation of measuring 3.4 cross 3.1 cross 3.2 right anteparamedian frontal lobe. The patient underwent right frontal craniotomy with total excision of lesion. Histopathology examination revealed ependymal cells arranged as perivascular pseudorosette and sheets with mitotic activity brisk. So immunohistochemistry is positive for L1 cell adhesion molecule, which is surrogate marker for ZFTM fusion, a suggestion of supratentorial ependymoma grade 3. So post-operative MRI brain showed no residual recurrent lesion. Patient received adjuvant radiation 54 grain 30 fraction IMRT using Rapidar. So post-radiotherapy follow-up, MRI brain showed post-operative change in the right frontal region with no evidence of residual recurrent lesion. So supratentorial grade 3 ependymoma with L1 cell adhesion molecule positivity represents a biological distinct and aggressive pediatric brain tumor subtype. So molecular classification is essential for accurate diagnosis and propagation. So L1 CAM immunopositivity is a practical surrogate for ZFTA fusion. So gross total excision followed by adjuvant radiotherapy remains the cornerstone of management. So in the era of precision oncology, integration of histopathology with molecular markers is indispensable for optimizing outcomes in pediatric supratentorial ependymoma. So on conclusion, supratentorial ependymoma in children is rare but potentially curable with multimodality treatment approach. Gross total excision followed by adjuvant focal RT provides external local control with acceptable toxicity. Sir?
After surgery?
6 months follow.
At 6 months.
Thank you.
May I invite Dr. Ashwati Ashok for the next presentation?
Good morning, everyone. Today I'm here to present a poster titled Management of Atypical Extraventricular Neurocytoma, a rare CNS tumor. Introduction. Central neurocytomas are rare WHO grade 2 neuroectodermal tumors, accounting for nearly 50% of adult intraventricular lesions, and their rare extraventricular counterparts arise in the brain parenchyma or spinal cord. And my aim is to determine the radiopathological features of extraventricular neurocytoma from other neuroglial tumors, and to assess the role of adjuvant radiotherapy in a typical extraventricular neurocytoma, and to determine the clinical utility of K67 in guiding the EVN management. My patient was an my patient was on 660. Oh, can I? Sorry. My patient was a 67-year-old male presented in June 2025 with an acute onset of headache and multiple episodes of vomiting for 4 days. And he was evaluated in the local hospital and CT brains was taken and showed it a large right frontal lobe intraparenchymal mass with 8.9 mm midline shift and subfracant herniation. And angiography was also done which showed no AVMs. And he underwent surgery at the neurosurgery department, James C. Court, and right frontotemporal craniectomy and excision in July 2025. And intraoperative findings were moderately vascular lesion in the frontal lobe. And post-op HPR reported as the morphology, monomorphous cells with a salt and pepper chromatin and chicken wire capillary network. ISC was done, inert synaptophysin was positive, GFAB, IDH, EMA was negative, and ATRS was retained, and it showed elevated K67 index to 50 to 60%. And we have, and before treatment, we have taken an MRI which showed no residual lesion. So we proceeded with the adjuvant radiotherapy as the K67 was high to mitigate high risk of recurrence. The dose and fractionation was 55 gray in 30 fractions, 1.8 gray per fraction. The PT was CTV plus 5 mm margin, and we use the IMRT technique. And this is the IMRT treatment plan picture, which shows the dose distribution in the axial, coronal, and sagittal views to confirm the high dose to the target region and to spare the OIRs. And this is the second picture is a DVH picture, and we can see that excellent coverage of the target volumes achieved by sparing the normal tissues. And we have advised him a 3-monthly follow-up, and current status of the patient is he is now clinico-radiologically stable, and he also underwent a right frontoparietal craniectomy defect, right autologous cranioplasty last month. And coming to the discussion, by all the review literature review, extraventricular neurocytoma surgery is the main key prognostic factor. When if surgery is a gross tumor resection, and if there is no risk factor associated, we can go for observation. And if in the if any atypical histology is present, we go for adjuvant radiation. Or if the surgery is subtalar resection or biopsy, or if the tumor is in the functional areas, we go for adjuvant radiation. And I like to conclude, given the rarity and the variable prognosis of EVM compared to central counterparts, this case underscores the necessity of adjuvant radiotherapy for atypical variants with high proliferative index to ensure optimal local control even following gross total resection. I would like to thank the Department of Radiation Oncology and Department of Pathology and Department of Neurosurgery for their valuable support.
Good. Can you show the aim? Can you show the aim? There are 3 aims. Have you addressed these aims, objectives in the discussion?
No, sir.
No, you have given 3 objectives, isn't it? So have you discussed this in your presentation?
No, sir.
Okay, thank you.
Next, we will invite Dr. Fatima Kasturi for the presentation.
Good morning, all. I am Dr. Fatima Kasturi. I am here to present a case of paranasal sinus metastasis from carcinoma endometrium. Endometrial carcinoma is the most common malignancy of the female genital tract in developed countries with an estimated annual incidence of approximately 3 to 25 per 1 lakh women worldwide. The most common location for metastatic disease are pelvic nodes, lung, upper abdomen and liver, and rest frequently metastasize to brain, bone and skin. The metastatic disease to paranasal sinuses are rare, with exact incidence is not well established, accounting for less than 1% of all distant mets from endometrial carcinoma. Here I present a case of 53-year-old female. She is a known case of carcinoma endometrium diagnosed in 2019 elsewhere, and she underwent total hysterectomy with bilateral salpingo-oophorectomy, and she presented to our side in 2022 with pelvic recurrence and treated with secondary cytoreductive surgery followed by external beam radiation treatment with 45 gray in 25 fraction and brachytherapy, and she was kept under follow-up, and in 2023 she developed peritoneal carcinomatosis and she was managed with systemic chemotherapy and she was started on tab-letrozole. And in 2025 November, she presented with persistent headache, vomiting and epistaxis. And on examination, she had right ptosis and she was evaluated with MRI brain with orbit, which showed a 2.9 into 3.2 into 2.7 centimeter enhancing lesion in the right posterior ethmoid sinus extending to right orbit with optic canal encasement and bony erosion. This is the MRI picture showing the lesion, and on biopsy from the right nasal mass showed poorly differentiated adenocarcinoma with IHC CK7 patchy positive with diffuse strong ERPR positivity and negativity for CK20, WT1, PAX8, P40, CEA and GATA3. Findings are consistent with metastatic endometrial adenocarcinoma to the paranasal sinus. And patient received palliative radiation treatment with 30 gray in 10 fractions, and she was on follow-up with hormonal treatment. Discussion. Endometrial adenocarcinoma is the most common histological subtype of the endometrial cancer, accounting for 75 to 80% of cases, and other histologies, clear cells, papillary, serous, squamous and mixed types are less frequent but more aggressive, and metastasis to paranasal sinuses is extremely rare, most often arising from renal cell carcinoma followed by breast, lung and prostate primaries. Only a few cases of endometrial carcinoma metastasis to paranasal sinuses have been reported, typically indicating the advanced disease and managed with palliative treatment. To conclude, paranasal sinus mets are rare and may present with non-specific sinonasal symptoms such as epistaxis, facial pain or swelling, eye involvement, headache and nasal obstruction. In patients with non-endometrial carcinoma, these features should raise the suspicion for distant metastatic disease, and early recognition is important as the diagnosis significantly alters prognosis and guides subsequent management towards appropriate palliative or systemic treatment. Thank you.
Did you go for a molecular classification even after different progression? Did you?
Initially, she had surgery outside hospital. We didn't have the HPR.
Like you could have heard that pathology specimen and reviewed with the
molecular
classification. Yeah.
Paul mutation.
Yeah?
Biopsy from nasal. P53 not done.
You have not done a molecular class. Have you looked at the P53?
Yeah.
Paul P53?
Should done. We have done the P53 with the slide review. It was wild type.
Where is the result? You have not shown it. Is it shown?
No, sir. Not, sir. No, sir. Not included.
You have done it?
Sir. In 2022.
Next presentation will be done by Dr. Sahidat. Please.
Good morning, myself Sahida. This is based on a study conducted in our institution, clinical outcome in EGFR positive non-small cell lung cancer patient who received tyrosine kinase inhibitors. Introduction: lung cancer is broadly classified into non-small cell and small cell lung cancer. EGFR mutation is an activating alteration in the EGFR gene that leads to constitutive tyrosine kinase activation, driving proliferation and survival of tumor cells, predominantly in lung adenocarcinoma. Aim: to assess the progression-free survival and overall survival in EGFR positive non-small cell lung cancer patient who received tyrosine kinase inhibitors. Methods: it is a retrospective cohort study in biopsy-proven EGFR positive non-small cell lung cancer patients who received tyrosine kinase inhibitors between January 2020 to December 2024 at GMC Thrissur. Data analysis using Kaplan-Meier survival analysis and log-rank test used to compare between various subgroups. Results: a total of 78 patients were studied. Out of them, 49, approximately 62.8% were males, and 29, 37.2% were females. Age ranges between 37 to 85 years with a mean age of 64.2 years. Most of the patients presented in advanced stage 4 disease, approximately 76%. The disease control rate, that means stable plus good response, approximately 41%. The median overall survival for entire cohort was 18.6 months with a 95% confidence interval 15.2 to 22.1 months. Overall survival in erlotinib is 19.4 and geftinib is 17.8 months. Log rank chi-square 0.84 and p-value 0.36. Median progression-free survival for the entire cohort was 9.8 months with a 95% confidence interval 8.1 to 11.4 months. Progression-free survival for erlotinib is 10.2 and geftinib is 9.4 months. Log rank chi-square is 0.62 and p-value is 0.36. Conclusion: EGFR positive non-small cell lung cancer has a better response to TKI. Stage of the disease significantly influenced the overall survival. There is no statistically significant difference in overall survival or progression-free survival between erlotinib and geftinib treated patient. I thank Dr. Prema, HOD, to guide this study. Thank you.
Thank you. None of your patients received other TKI inhibitors, osimertinib or afatinib or chemo plus the targeted treatments?
No, sir. These patients are, more of the patients were in advanced stage disease.
Yeah, usually you get most of them come in advanced stage early lung cancer. Now the standard of treatment is changed. Either your chemogeftinib gives a median progression-free survival of 18 months, or if you osimertinib gives 18 or 24 months. Osimertinib chemo is the standard now. Then lasatinib, amivantamab is also consistent first line options. Now usually they go for a chemo plus TKI inhibitors.
In your conclusion, you said EGFR positive non-small cell lung cancer has a better response. How can you say that? You have a control group?
No.
You got my point? Okay.
Thank you. Next, we invite Dr. Kiran G for the next poster presentation.
Good morning, everyone. I'm here to present our study, a retrospective observational study that assesses the impact of radiosurgery in local control based on volumetric analysis in cranial nerve schwannomas. Cranial schwannomas are benign nerve sheath tumors seen on the course of any cranial nerve. Even after a gross total resection, some tumors may recur, with 50% having partial regression progress during follow-up. Our aim of the study was to assess the impact of radiosurgery in local control of cranial nerve schwannomas. After obtaining clearance from the Institutional Ethics Committee, medical records of 40 patients were collected and analyzed. Patients who had both pre-treatment MRI and last follow-up MRIs were used for analysis. A total of 24 women and 16 men were there in the study. The median age at presentation was 36 years. 17 patients had lesions on the left, 20 on the right side, and 3 had bilateral lesions. 29 patients had undergone surgery prior to presenting for radiotherapy, of whom 5 have complete excision post surgery, and 1 patient underwent surgery after radiotherapy due to increase in size of the lesion. 5 patients received conventional fractional radiotherapy to a total dose of 50 to 54 gray in 28 to 30 fractions over 5.5 to 6 weeks, and the remaining 35 patients were treated with serotypic radiotherapy, receiving doses 12 to 13 gray in single fraction to a 30 gray in 5 fraction depending upon tumor size and volume. The lesions were, while for treatment, the lesions were contoured using brain lab elements and iPlan RT, and the treatment planning was performed using Varian Medical System. The median gross tumor volume was 3.4 cc and the median planning target volume was 4.4 cc. Post-treatment contrast enhanced T1 weighted MRI sequences of slices 1 to 2 mm were used for tumor assessment. The volumes were imported to Varian Medical System and measured and performed, and volume measurements were performed on axial slices and was manually related on each slice, and the software calculated the tumor volume based on slice thickness and intervals. The volumetric assessment, the measurement process typically required only a few minutes per case. The volumetric assessment of schwannoma was expressed in cc, cubic millimeters, as centimeters. The baseline size was defined as a volume when they presented for radiation. The growth rates were calculated based on the last follow-up scan. The study was a analysis of the radiological data. The pre-treatment and post-treatment volumes were analyzed using a paired t-test involving 2 paired groups. P-value less than 0.05 were considered statistically significant and was analyzed on SPSS software. During a median follow-up of 54 months, there was an average 49% decrease in tumor size and average difference of 2.3 centimeters with a 95% confidence interval of 1.3 to 3.4 centimeters, which was statistically significant if p-value less than 0.001. One patient required post-op radiosurgical excision view of progression of the size of the lesion, and one patient had a mild increase in volume of 11%, and another patient had a mild decrease in the volume of 9%, which was not included in the calculation of the paired t-test analysis. The low incidence of additional interventions prevented the calculation of risk factors, and no variables are associated with radiological failure. This study had a few limitations. A median follow-up of 54 months is relatively brief, and extended follow-up would be required for more definitive conclusion, and the use of multiple modalities of radiation, even though the BED equivalence was maintained, reduced variability, and third, the absence of symptom-oriented clinical follow-up measures restricted the strength of the conclusion. Yes. Yes, sir. The study duration was around 8 years, 2014 to 2022. Thank you, sir.
For the last e-poster presentation for the session, I invite Dr. Teresa Thomas.
Good morning to all. Today I am presenting a poster. The title is Evaluation of Trends in Cancer Incidence for the Last 3 Years in a Tertiary Cancer Center in Alappuzha, Kerala. Guided by Dr. Sajeev George, our HOD. Introduction. In India, non-communicable diseases were estimated to account for 63% of all deaths, and cancer was one of the leading causes, 9%. There has been a steady increase in the incidence of cancer in Kerala over the past decade, with a rise in both crude rate and age-adjusted rate. Our aim is to analyze the trends in cancer incidence for the last 3 years in Government TD Medical College, Alappuzha. The method was demographic data of newly registered patients in the Radiation Oncology OPD, Government TD Medical College, Alappuzha, in the year 2023, 24 and 2025 were collected from case records. Data of carcinoma breast, head and neck, cervix, colon, endometrium and rectum cases were collected. Descriptive statistics was used for analysis. Results. These are the graphs showing cancer site-wise distribution of the 3 years. And this is the table showing cancer site-wise distribution. And for breast cancer, the proportion in 2023, 40.5%, in 2024, 43.6%, in 2025, 42%. For head and neck cancers, 15.2%, 15%, and 13.5% respectively. Cervix, 4.7%, 4.1%, and 3.5% respectively. Colon, 3.7%, 4.3%, and 4.4% respectively. Endometrium, 4.9%, 5.1%, and 3.5% respectively. For rectum, 2.6%, 3%, and 2.2% respectively. The total cases per year was in 2023 983, in 2024 1131, in 2025 1217. Of that, females were more predominant. Site-specific age distribution. The peak age group for carcinoma breast, rectum and colon was 50 to 59 years. For carcinoma endometrium, there was strong predilection for the postmenopausal age group, especially 60 to 69 years. For head and neck cancer and carcinoma cervix, peak age group is 60 to 69 years. Next is gender-wise distribution. Male-female ratio was done. For head and neck cancers, 6.8 is to 1. In 2024, 7.1 is to 1, and 2025, 6.2 is to 1. For colon, 1.3 is to 1, 0.9 is to 1, and 1.1 is to 1 respectively. For rectum, 1.6 is to 1, 1.8 is to 1, and 2.2 is to 1 respectively. Head and neck cancer show pronounced male predominance. Rectal cancer, moderate male predominance, and colon cancer, near equal sex distribution. Conclusion, the total number of cancer cases per year shows an increasing trend. Females were most affected than males. Carcinoma breast was more prevalent and the most common cancer among females. Colon and endometrial cancer shows a rising trend. Cervical cancer shows a declining trend. Most of the cancers show clustering in the 5th and 6th decades of life. Thank you.
Thank you. You said how do you make a comment like the females are most affected than males? That's in your data only. You cannot make a comment like that. And also lung cancer, nothing, no lung cancer reported in your center? Sorry. Which is the commonest male malignancy? One of the commonest male malignancy in Kerala.
It's lung. According to studies, it is lung.
Yeah, this data is from your institute, isn't it? So it's not the incidence. Because when you say incidence, it should be a population-based. It's only a hospital data. It shows only a frequency because there is a referral bias are there. So you cannot call it as an incidence, and you cannot interpret that result because it shows that your referral bias comes there. Got it?
Misuse the word incidence and frequency and prevalence. This has to be clearly thought through. I think only then we understand cancer. Incidence is the total number of new cancer cases occurring in a defined population in a defined period of time. Frequency is the number of cancers in a hospital. But what is the use of this? Reasonably good data. What is the use of this data?
Because due to the changing lifestyle, endometrial cancer and colon cancers are increasing according to our data.
So you cannot say that. What the main use of this is how to plan your services. The hospital-based data. So if you have a lot of head and neck cancers, maybe you should have a new head and neck unit or something like that. Thank you.
Thank you, sir. So that comes to the end of the poster present session. Thank you all for your active participation and special mention to the judges. I'm extremely sorry for the technical glitches. So there will be a short tea break. We will join exactly at 11 o'clock for the much awaited session on cancer policy. Thank you all.
Consultant, General Hospital, Thrissur, and Dr. Sajid A, Additional Professor, RCC Trivandrum. Dr. Sajid shall join later. Now I invite Dr. Rahul Krishnatri, Professor, Radiation Oncology, TMH Mumbai, to speak on the topic.
Sure, thank you. So good afternoon, everyone, and I think you're still awake after your nice lunch break, right? So I'm focusing basically on biliary tract and gallbladder, not the hepatic or the liver part, because I think that's covered in another session today, right? So if we divide this hepatobiliary tract, it is intrahepatic cholangiocarcinoma up to the second level of bile ducts. From there to the cystic duct joining, it is called as perihilar. Beyond that, it is distal till the ampulla, and ampullary is the ampulla of water where the pancreatic duct joins. And apart from that, it's gallbladder cancer. Now, it is quite heterogeneous, but usually put together, especially the gallbladder and the bile duct cancer, biliary tract cancer. I don't think in Kerala you see much of gallbladder cancer until unless you have too much of immigrant population here. It's mainly biliary tract, which is more equivalent to the Western population. But just to bring out the differences, so if you look, the biliary tract, which is on the right side of the the slide, which is again rising in trend, but it is more male predominance and it is more in older population, as compared to the gallbladder, which is in younger and female population. Again, trends for both are rising, right? And the regional differentiation of epidemiology is basically for the gallbladder cancer, which is more in North India, Pakistan, and Bangladesh and Nepal. Then going to the northern parts of the Africa and South America. So these are the regional endemic areas for gallbladder cancer. So coming to the treatment, I split it for explanation purpose, basically for the resectable ones. So those are to be resected. The surgery remains the treatment of choice if it is resectable. And then there is something called as unresectable or locally advanced, which is non-metastatic to be. So if you look at the evolution of the evidence from where whatever recommendations have come, it was earliest the SEER data of 2008, which was almost 4,000 patients analyzed. And it showed that if you have, sorry, can you see this clearly or no? So if you have a node positive disease or T2 onwards disease, there's an almost 5 months survival benefit if you add adjuvant radiotherapy to these patients, right? And these were all mixed, but mainly biliary tract cancers. Now, there were further studies, or the 20 retrospective studies which were meta-analyzed in 2012, which has almost 6,000 patients, right? And which shows that there was clear benefit of having adjuvant therapy, but then it showed that chemotherapy was better than chemo-RT or RT alone. And then there was second SEER analysis in 2014, which said that RT importance was only when there was node positive disease and not in the other indications. Now this was quite confusing for everybody, and repeatedly the guidelines would get revised. So I'm just trying to confuse you and bring you to some point, don't worry, so just hold on with me. And then in 2015, the meta-analysis came, which was again 10 retrospective studies of around 3,000 patients, and it said there was no significant improvement with addition of RT or CTRT. But chemotherapy alone had a significant benefit in survival. And this is how ESMO kept on, bumping RT in and out of the adjuvant therapy of biliary tract cancers. Now, this was the first meta-analysis, which was basically for gallbladder cancer purely. Otherwise, what all you saw till now was mixed of gallbladder and biliary tract cancers. Now, if you can imagine looking at this data, what it shows in 2017 is in T3N0, right, the chemo radiation is almost 32% 3-year survival, which gets to 20% if chemo alone, and radiation is 32%, and again, surgery alone is 19. So it's almost doubling with, chemo radiation. And chemo alone is not very, very critically adding value to gallbladder cancer. Same is for other N1 or negative margin, positive margin tumor indications. So what it suggests probably is the heterogeneity of incorporating gallbladder cancer percentage would have changed all the results or fluctuations that you might have seen. And what you understand probably is RT is less effective probably in biliary tract, and chemo is more effective there versus gallbladder cancer. So let's see more. So this was only prospective data that we had, SWOG 0809, which was phase 2 single arm study, and which showed that there was a significant survival improvement as compared to the historical cohort of 65%, especially in the gallbladder cancer. Now, if you look at this table, this is the most critical table that I'm going to stem upon what I'm saying. Although the numbers are small, these are quite reproducible in larger numbers as well clinically. So if you see the hilar or the extrahepatic cholangiocarcinoma, the local control and the distant control are almost equal, with the majority being distant metastasis, right? So RT is not affecting local control improvement. So it's not a radiosensitive tumor, right? Whereas if you see the gallbladder cancer, local control is excellent, and what we are failing is mainly distally, 50% of that. So 44 out of 52 all failures is systemic failure, despite having the most modern GEM-CAPE chemotherapy, right? So this is why these two diseases are very, very different from one each other. Till this trial, I think till 2023, the ESMO said adjuvant chemo RT is indicated based on the SWOG and the SEER database. Now this year it has been kicked out because they don't consider gallbladder as a separate cancer. Now this is the phase 2 study from Tata, where we did GEM plus CIS versus consolidation CT-RT. Now this phase 2 study was to find the signal. This was not to compare the two things. So it was, the cutoff was 77%, and to see if we are above that, then both those things should be compared in phase 3 trial. So there were 98 patients total, out of which 45 in each arm. They were quite balanced, and what we have long-term outcome now, the previous one is already published, the early outcomes, they were all equal. Now even the long-term outcome is being considered for publication, so this is the data from there. It is not yet in the print. At 65 months, which is 5-year follow-up data, the survival is almost same, almost 60% in both arms, right? And 5-year DFS is also 50-55% same. Now this is compared to the BILCAP study that you have for chemotherapy for biliary tract cancers, right? But this is gallbladder, purely gallbladder cancer study. I hope you're still there with me. Don't get confused between when I'm switching them, right? And then if you look at it, it is little better than the SWOG too, because probably SWOG study had more resection positive, margin positive disease. So from that, now we are moving to phase 3 randomized trial, which is ongoing, which is GB-JECOR 2. So if to summarize, for T2 plus cancer undergoing R0 resection or T3N1 or margin positive diseases, adjuvant treatment is superior to surgery alone. Now among that, probably CT-RT is better for gallbladder. For biliary tract, probably it's just chemo. RT doesn't still have a very big role. Now coming to the unresectable, locally advanced biliary tract and gallbladder cancers. Now this is a table which shows comprehensively various, I think the screen is very bad, right? Or can you read? No. I'll share the slides later on if you want. Somebody can contact me on email, don't worry. So, can you just decrease the granularity of the screen? Can something be done? No? Yeah? I don't know what you want to do, but there is too granular, it cannot be seen there. Yes, okay. Okay. So anyways, these are the various focal therapies that we have for biliary tract cancer, and this was a good meta-analysis published in 2021, which compared EBRT, ablation, SIRT, something like TARE, then TACE, and then HAI or hepatic artery infusion. And these are the various studies that we had. So what we see is probably the pooled PFS was best for TACE and EBRT, right? And if you see for the ablation, overall survival was best with ablation, because they are small tumors, you will choose them or select them that way, and then you can do repeated ablations for those tumors. Now this is another seminal paper which you should know, which is from US, and it's a combined data of multiple centers. What it shows that dose has a value. So what I was telling you in even adjuvant session, that if you have above 85 gray, if you're able to deliver that dose, the survival and the local control is significantly better, which is of the blue line, right? And the yellow line is the lower doses. So if you're able to do SBRT or a higher dose in biliary tract cancer, you can significantly have an impact with radiation. Now this is another study which is again the pooled data for proton therapy. So it's much more safer and easier to do that dose escalation with proton therapy as compared to photon therapy. And again, what you see blue line is for HCC, and the yellow line is your biliary tract cholangiocarcinoma. So this is again phase 2 multicentric data, which shows significant impact by adding proton therapy or high dose to the biliary tract cancer. So just to summarize, dose of more than 80 or 85 gray is relevant, and of proton therapy or other methods of dose escalation will be more impactful for biliary tract cancer if you are able to escalate the doses. Now coming to the second part of the hepatobiliary cancer, which is gallbladder, right? Now if you look at 5 or 7 years ago, this is our own paper from our medical oncologist in TMH, which said based on 37 patients data, they made biliary gallbladder cancer chemotherapy standard with GemCis. I know after that AIMS studies also came, but if you look at, these were the first 4 patients treated with radiotherapy. These were not responding to chemotherapy, they failed chemotherapy, and because they were known and relatives of certain doctors in our hospital, they requested, can we give some PAL-RT, something like that, can we try, because patient was in well condition. It was just the scan was failing, right? And what was miraculous? This was pre-treatment and this was post-treatment, complete response. I'm just showing one patient for your eyes, but all the 4 were like that, right? This was quite remarkable and miraculous, which nobody had witnessed before. And based on that, we did a phase 2 study, which was a single arm, in which we did standard chemoradiation, right? 45 to 55 gray. So 45 to the CTV and 55 to the gross tumor in 25 fractions, with GemCis concurrent, right? This is the volume that you would see. So the red one is the gross tumor that we're treating, and the green one is the CTV that we are treating with the POTA nodes and everything. Now, out of 28 patients, almost 50% could undergo surgery, right? And there was almost 60 to 70% complete response, right? This was never happening with chemo only. Now, the cost was toxicity. There's no denial, and you will learn with that. So there were recurrent biliary leaks, so patients would need pectailing and all those things. That will settle down after some time, right? There was few patients who had duodenal stenosis and stuff. So what we learned from that was to select patients better for the next study. So you had to exclude patients with had stent or duodenal or coronary involvement, mucosal involvement, not the external wall involvement alone. External wall can be treated well. So if suppose there's a loss of fat plane or just adherence, that is okay. But you should confirm that there's no mucosal involvement by doing a scoping. So that patient can be easily treated, right? So this is just a systematic analysis which showed that there were only 2 prospective studies, one of which I showed you now and one from Chile, right, South America, which showed that RT was beneficial. And on the basis of that, we did a phase 3 randomized trial, which is Polka-GB. I'm sure you would have heard about it, at least if not known more about it. So this was presented in ASCO GI this year by Dr. Reena, who's a senior consultant in my department, and she is the PI of this study. So in this, we compared neoadjuvant chemotherapy versus chemoradiation in locally advanced gallbladder. So, no, it's okay. My throat is bad, don't worry. So the patients were mainly T3, T4 and node positive, but they were classically called borderline because they were not totally inoperable. We can come to that discussion later on. It's a TMS specific classification in which we could agree our surgeons to do this trial, nothing more than that. But it's basically advanced gallbladder cancer, which was not resectable upfront. They were randomized to 4 cycles of GemCis versus 2 cycles followed by chemoradiation followed by 2 cycles. And then they were reassessed for surgery or continuation of chemotherapy till 6 cycles. So the primary endpoint was survival, right? And the sample size calculation was based on 11 months to 16 months improvement with addition of chemoradiation. And for that, 314 patients were required. We could accrue only 124 patients over, 8 years almost, 61 in chemoradiation and 63 in chemo alone. And that's why we proceeded with the interim analysis, because it was going on, and it would have never got over with 300 patients. It's quite resistant, right? So the surgeons and medical oncologists in GI are tough. It's not easy to fight them. But results speaks for themselves, right? So there was completely balanced in both the arms. All patients completed therapy in both arms, almost 93 to 91% patients. And this is what is the most important part of the study, right? So there was almost 43% patients with complete response in chemoradiation versus 10% only in chemo alone, right? Second important thing, there was 44% patients progressed, right, on chemo arm. And this is while on chemotherapy. So if you look at your patients carefully, 3rd or 4th cycle, they will start progressing. They will stop responding. First they will stabilize and then they'll progress. And this is almost 50%, right? So if your surgeon says that if it is challenging to operate after radiation, then you must tell them 50% you will not be able to ever operate if you just give chemotherapy, right? So what do you want? And only 12 patients became inoperable locally because of RT. Now what this led to, right? So 5 years, the surgical exploration rate 65% versus 45%, R0 resection 84% versus 70%, despite being difficult surgery, right? And the survival impact almost double, right? So it is 10 versus 21 months at median, and 5 years is 17 versus 29%. Obviously, because of the event-free survival, so it is significantly better, 5 versus 10, and 11 versus 23. And if you can compare, the chemo arm outcomes are similar to what you have from AIMS. So AIMS is the only study which is only purely on gallbladder for the same chemo regimen. Now the toxicity part, which is little pinchy. So if you see overall, this p-value is not significant, but the feelings are very bad. They're significantly significant, right? So the surgeons will tell you it was so terrible to operate after chemoradiation. It must be difficult, but does it lead back to post-op care or inoperative failure? No, right? This is what the table tells you. And this data has been verified by our surgeons. We cannot go to publication without showing them, right? Other adverse events are mainly chemotoxicity, which was similar in both arms because they received the same chemotherapy. So key takeaway were, basically if the patient has T3, T4, node positive gallbladder cancer, downstaging is better, R0 resection rates are better, survival is better with radiotherapy. It's chemo alone is worse, right? So if I have to now move to more advanced unresectable disease, which is much more worse than this, and early POTA nodes. For this, what we have is basically the recent study from SGPGI, right? So what they did was, they allowed patients to complete chemotherapy. And the patients who did not progress on GemCis as a standard of care, they were offered as consolidation radiotherapy versus no treatment or observation. And in that also, if you see, the survival is almost double, although they finally merged together at 20 months. But if you look at the median survival, it's significantly better with radiation, the red one, okay? So if you look at the first graph, the median is somewhere around 12 months versus 5 months, right? So that's the difference. And that is why actually we don't agree once we know our Polka GV study trial data. So that means 70% would have progressed before they needed this question to be answered, because they waited for the patients who have not progressed on initial chemotherapy for gallbladder, which doesn't work, we know that. So 60 or 50% would have already progressed and dead. And we are trying to flock patients who have just responded. It would be rather better to offer RT upfront to those patients as well. That is what we believe, because chemo technically doesn't work in gallbladder cancer, whatever we know today, right? Then what is coming up is probably immunotherapy. This is the only abstract available, but this also shows quite dramatic results from China, right? So this is only 10 patients data, and it showed like complete response in almost 90% of those patients. So to summarize, biliary tract cancers are rising, whether it is cholangio or gallbladder cancer. T2 plus cancers in R0 resection also should be offered adjuvant treatment. Adjuvant RT is superior to surgery alone, but chemorats is better to both RT alone and maybe similar to chemotherapy in gallbladder cancer. Biliary tract, probably RT has to still redefine its role in adjuvant setting. Unresectable one, early ones which are not operable, maybe RT may have a place if we start using it more often in adjunct to our chemo guys, but we don't have a proper indication right now still defined in textbook. For gallbladder cancer, RT or chemo radiation is the standard of care. That is what we believe. Thank you.
Thank you, sir. That was an excellent and informative talk. And any doubt from audience?
Just a clinical scenario that we commonly encounter with cholecystectomies getting done. A patient goes for an unsuspected or maybe a cholecystitis, you do surgery, and finally on the histopath you end up having a malignancy which was not appropriately surgically staged. Then what do you do next?
So generally our surgeons will do a revision cholecystectomy for them. Yeah. We will not jump for RT in those patients upfront. If they don't want to get in because of some reason, then we might give CTRT. But that will be an inferior treatment.
Dr. Rahul, that was a wonderful presentation. So my question is, when is the appropriate time to do surgery after neoadjuvant chemo-RT?
So generally we assess them 2 to 4 weeks after chemo radiation finishes.
So you do CT or
PET CT.
PET CT?
For gallbladder.
Okay, so
this is about gallbladder.
Yeah, when do you do surgery?
It's about 2 to 4 weeks. Like हमारा waiting limb लंबा होता है, but 2 weeks में you can operate.
Within 2 weeks?
So 2 to 4 weeks you're doing a PET scan. After that, within 2 weeks you can operate.
Around 6 weeks.
Yeah, 6 to 8 weeks.
So surgeons are fine with that?
Yeah.
Okay.
They should be. There's not much of fibrosis at that time.
Okay.
Yeah. And they should be prepared for biliary leaks and repeatedly doing pigtailing. That's all.
Okay.
Nothing more than that.
Nothing more than that. So there is no increase in morbidity, surgical morbidities due to that.
So post-RT or post-operative hepatic failure generally does not occur if your volumes of liver are pretty gauged, right? So that you should be careful while contouring. You should not take too much of margins of motion and everything into the liver, right? Do some motion management so that your volume of liver is less, right? POTA, they will have challenge. So they should get prepared that the whole day will go to operate. Okay. After RT, the POTA, everything becomes one thing, right? So to dissect between planes of that is very challenging for them. Okay. So your surgeons have to be careful at that time. And you should not have hypodose fractionation in your POTA area.
Okay. And I'm sure that your surgeons have been doing this surgery for,
now for 10 years.
It depends upon their expertise also. And Dr. Shailesh is very... I have heard that he's very good in doing hepatobiliary surgery. So I think that also depends upon how your surgeons are good in doing.
No, so that is why I'm saying. So earlier they used to curse us. Now they are happy with it. Yeah. And anyway, now even in very advanced ones, they are okay for us to just chemorats and not operate also.
Really?
That is even better that they feel, you know.
So, but you have already decided on the plan before, no? It was the dose.
No, so we repeatedly review our plan. So baseline plan is you go ahead with neoadjuvant therapy and see the response. Yeah. Once you see the response, then they decode whether they're going to operate or they're going to not operate.
Okay, so if they are not going to operate and you have decided that this patient was potentially resectable at the first time, then what do you do?
We don't
after
take
that?
potentially resectable, we take borderline operable or not operable.
Okay, so if the surgeons are not doing surgery, then what is the next plan?
They continue and finish their 6 cycles of GEMSES.
Okay.
Yeah.
Okay. Thank you.
Thank you very much, sir, for that comprehensive and enlightening presentation. And I now request the chairpersons to hand over a token of appreciation to Dr. Rahul Krishnatri. I now request Dr. Praveen J. Nainan to hand over a token of appreciation to our chairpersons. Thank you very much. Our next session is a panel discussion on multimodality management of locally advanced pancreatic cancer. As panelists, I invite Dr. Amita Sharif, Consultant, Medical Oncology, Daya Hospital, Thrissur, Dr. Praveen J. Nainan, Professor, Radiation Oncology, Medical College, Alapura, Dr. Jacob John, Consultant, Radiation Oncology, Muthoot Hospital, and Dr. Sharath K. Krishnan, Associate Professor and HOD, Surgical Oncology, Medical College Hospital, Thrissur. And I request Dr. Haridas M. Nair, Associate Professor, Radiation Oncology, Amrita Hospital, Kochi, to moderate the session.
So I think since we are running short of time, we'll just quickly go into the panel discussion part. So we have Dr. Praveen, Dr. Jacob, and from the radiation oncology community, Dr. Sharath, who will be leading our surgical discussion, and Dr. Amita for our medical oncology consultant. So just as an introduction, we know what CA pancreas is. Generally a malignancy with poor oncological outcomes, hardly 15 to 20% actually present in a resectable scenario, with a poor overall survival that we have seen, and nothing much that we have been doing seems to improve the outcome of pancreatic malignancy. A lot of important prognostic factors which decides the prognosis of CA pancreas. What we have tried to do is, by improving outcomes, we have tried to incorporate neoadjuvant therapies to improve the R0 resection rates and more effective systemic treatment, trying to improve the outcomes of pancreatic cancer. So this is a meta-analysis which tries to give you the real-life scenario where with addition of neoadjuvant treatment and improving the possibility of resection, we are able to improve the survival of even borderline resectable and locally advanced cases to almost the same as the resectable cases. But again, despite all that, it is just a median survival of 20 to 23 months. So we'll go through first one case. If time permits, we'll go to the second case as well. First case, and as we go, we'll just have a discussion on the different aspects that we would like to discuss. So this is a 48-year-old lady with no comorbidities, good performance status, who was evaluated for just intermittent nausea, a sensation of bloating. Blood investigations revealed a mildly elevated total bilirubin, otherwise everything seemed okay. Just a routine ultrasound showed something suspicious in the pancreatic head region and was advised a cross-sectional imaging. So I think I'll just go to Dr. Sharath to just help us on what imaging of choice would you suggest for these kind of patients who come with some suspected lesion in the pancreatic head.
Most of the time, the CT scan is done from the peripheral side, and it's almost always suboptimal. What we need is a triple phase proper CT scan involving all the phases, the pancreatic protocol CT, with an early arterial and the late arterial. The late arterial gives you the pancreas delineation and definitely the portovenous phase. So if you have the proper CT scan, then we have to look into the SMA and the portal vein, how much it is involved. When it is less than, and you have to also look for the distant metastatic disease, and especially the non-regional nodes. Sometimes you may have a intra-aortocaval or a paracaval nodes, which may suggest it is a metastatic disease.
So I think we have to, I think the take-home point is that a triphasic CT or a multiphasic CT incorporating these phases, early arterial phase or late arterial phase and the portal phase is what would give you best assessment of the pancreatic lesion. Look at the vascular involvement, which is important. I think sir would also like to touch upon the certain aspects from a surgeon's point of view is to look at the resectability criteria, which is an important factor.
Yeah, this resectability criteria is what you have to look into that CT, as we have discussed earlier in that meta-analysis. You are trying to get down to a resectable level of survival. So when the portal, it's artery that is important. If it is encased or if it is fully involved, greater than 180 degree, most of the time the survival outcomes are bad, whether you do a surgery, whether you do multimodality treatment. So there also you need to select properly. So it is a resectable patients means the vessel and the superior artery and the vein both are free from the tumor. When it is having a contact more than 180 degree on the vein and less than 180 degree on the artery or the celiac axis, it will be a borderline disease. And anything more than that will become an advanced disease or an inoperable disease.
So routinely you would not ask for an MRI. Probably when would you do an MRI in case you would ask for an MRI specifically?
MRI, it doesn't give an advantage over a CT. A CT will be more preferred, but in cases where contrast cannot be used or in such situations, we may go for an MRI. The response assessment also, MRI will not give you an edge over the CT.
Okay. And anything with specific to chronic calcific pancreatitis, do you make any adjustments or ask for any specific imaging for chronic calcific pancreatitis?
Pancreas also can be better delineated in CT scan. MRI will not help you much on that also.
So I think from the summary point, we have to look at certain aspects. You have to look at the resectability criteria, which is a standard. The NCCN criteria is something that we standardly follow in Wildover. There is a concept of using multiple factors, the anatomical factors, which is what we discussed with the relation of the lesion to the major vessels, including most importantly the artery, which decides the resectability, the biological factors, especially the CA99, which as a tumor marker would be used, and certain conditional factors like the general condition of the patient, the comorbidities. And based on this, you should be able to categorize patients into resectable, borderline resectable, and locally advanced, potentially resectable or unresectable. So this is that borderline resectable or that potentially resectable, locally advanced is a group where we have maximum to do and try to improve their outcomes. In case sometimes we have these kind of patients who presented with, most of the time we have patients presenting with obstructive jaundice. Do you insist on a stenting upfront or do you wait? When do you insist on a stenting?
Our patient that is shown in our clinical scenario,
the bilirubin is 2. Only 2.
If it is a resectable disease, the cutoff which is kept is 15 milligram, but we go up to 20 because stenting a patient takes you more of morbidity into surgery. So if it is a resectable disease, we will go upfront even on a bilirubin more than 15, maybe up to 20 also. But in an unresectable or a borderline resectable, because you need to give some sort of neoadjuvant treatment, we may go in for stenting at higher levels of bilirubin.
And mostly it will be a plastic stent.
Mostly it will be a plastic stent. Metallic stents are difficult to operate and difficult to deal with and do the anastomotic part of the surgical treatment.
Okay. So to summarize, you do a CT, assess the resectability, and then rule out a metastatic disease before you go in ahead with a curative intent treatment. So this is the patient in question that we have, and her CT abdomen was done, which shows lesion in the uncinate process bar head of the pancreas, which is abutting the SMA as well as the SMV, not encasing, less than 180 or approximately 180 degree contact with the SMA. you have a lesion, this is the lesion with contact with the artery, as well as here the vein and the artery can be separately seen. So this is classifiable as a borderline resectable case as per the guidelines or as per the resectability criteria. Now, confirmation of diagnosis, generally, I think so would agree, we prefer generally endoscopic ultrasound to take the biopsy and confirmation of the diagnosis.
We may be able to do with a side viewing endoscopy if it is going into the, this doesn't look like going into the duodenum, so you might have to consider an endoscopic ultrasound in this patient.
And tumor markers, you would classically do the CA99.
CA99, unfortunately, 10 to 15% of the patients don't have a CA99 elevation, so that is also a problem when you reassess after neoadjuvant, especially in this patient. Okay. And the diagnostic lab is not of much favor in our setting. We will proceed with imaging and clarify the metastatic disease on imaging. We don't do it on regularly for pancreas.
Okay, so only diagnosing only in very suspicious scenarios where you
especially if it is 10,000 and more, say 99, and this tumor is little larger, more than 3 centimeters, 4 points. So we may, it's a plus or minus. Okay. There are centers who do diagnostic on a routine basis also.
Okay. Amita, in your experience, if the patient came to you, would you insist on a PET CT to rule out distant mets?
With CTs, equally enough. If it is locally advanced, I would definitely consider a PET CT.
So if it is a borderline syndrome, you just would maybe do a CT chest and be happy with that. Okay. So PET CT is not mandatory. Diaglab is again not mandatory, but look at the individual patient. Take a call based on, if you have certain suspicions, then you can use it as a problem-solving solution. So again, FAPI is something that is again being promoted in the pancreatic thing. Amita, any genetic testing or biomarkers that you would insist when the patient presents to you?
Usually in resectable and borderline pancreatic cancer, we do not go for genetic testing. If it is locally advanced, inoperable or metastatic, we may consider giving going for genetic testing, especially we have role for PARP inhibitors as maintenance. No. Otherwise, in borderline setting, no.
Okay. So I think we have reached the scenario where we have confirmed this patient is having an adenocarcinoma of the pancreas, borderline resectable. So you want to
this is by guideline. They say we need to evaluate every patient with some genetic testing. Maybe the concept is like it may proceed to advanced metastatic disease at some point of time,
yeah.
And we may have to add on reagents depending upon the availability and socioeconomic status of the patient. That is the...
Yeah, I think the guidelines suggest we can consider, but I think in our practical scenario, most of our patients, we would not be doing it on a routine basis. So we have a patient who's now diagnosed with adenocarcinoma of the borderline resectable pancreas and non-metastatic disease. Next, they have to take a decision. So I think this is a patient you would generally refer for neoadjuvant treatment, right, sir?
Definitely, this patient is borderline, definitely borderline. So we don't usually send patients for neoadjuvant, especially in this patient, especially this lesion is pushing both the vein and the artery anteriorly, and the portal vein is not seen clearly. So this is more than borderline. That's what I see. If you see the images in serial sections, you may delineate it better.
Yeah. So technically, because it is less than 180 degree, it technically falls. But again, because the artery is there, it's not a minor involvement of the SMA
now
artery.
More and more evidences are coming in favor of neoadjuvant, even in resectable pancreas. So definitely we should go ahead. We don't practice it even though.
Okay. Praveen sir, what do you think is the general rationale why we should give neoadjuvant therapy in whatever form? We have discussions on what type of neoadjuvant therapy or what is the optimal neoadjuvant approach.
Yeah, in a borderline resectable pancreatic cancer, although RT does not have much of a role, but still we have something to do in there. Basically, you have something known as the local control, which is better with concurrent chemo RT. And also you have the R0 resection rate, which obviously is better with concurrent chemo RT. So like the ECOG trial, which came up first, showed the importance of RT, combined gemcitabine RT versus gem alone, which had a better local control rate. And you have the CONCO trial, which shows that the RO resection rate is better. So definitely chemo RT would be the best option as a neoadjuvant.
Okay. So to summarize, I think probably any neoadjuvant therapy, so apart from RT, any neoadjuvant therapy, the aim at least in pancreases, it's generally a systemic disease. So you have to control both the systemic occult disease as well as the local disease. And it also gives us time to select the right patients before proceeding for a major operation or a major morbid surgery. And the resectability rates are much better. That generally will improve the outcome of the patient as well. So there are a lot of options. Again, we have neoadjuvant chemotherapy, neoadjuvant chemoradiation, a combination of both resulting in something known as the total neoadjuvant therapy. At least in GI cancers, I think neoadjuvant therapy has become the norm in many scenarios. And we are again moving towards the total neoadjuvant therapy as well. A lot of evidences have come up, like sir was suggesting, where it is proven that neoadjuvant therapy is better than upfront surgery. And therefore, that should be the case in the borderline resectable pancreatic cancer onwards. In resectable, there is some evidence, but again, it is not come as the definitive first line in all scenarios, but at least in borderline resectable, based on the current evidence, you have that compared to upfront surgery, neoadjuvant therapy in whatever form improves the outcome. Now, the debate is always on, is it neoadjuvant chemotherapy or is it neoadjuvant chemoradiation? What can be done? We have 3 trials which have looked at this, and all have shown it has employed different strategies, one with FOLFIRINOX, one adding hyperfractionated RT along with it. The other was just FOLFIRINOX with concurrent chemoradiation in 2 scenarios. And these are one of the few recent trials, especially the PRIOPANC-2 trial was just recently, the full publication has come. The Alliance trial, it has its own criticisms, which if time permits, we'll discuss, was a negative trial. The PRIOPANC kind of was equivocal, both showing good results, whichever approach you take, the patient benefits. The governance trial showed actually the addition of RT along with S1 was better than Gem-Nab-Pacli. So again, there is too many variations in what we are using. There's no one standard. The PRIOPANC-2 trial, we'll just touch upon it. If Amita could just take us through the trial details.
For this patient, borderline resectable pancreatic cancer, I would probably consider neoadjuvant chemotherapy in the form of FOLFIRINOX because of the following reason. 1, the patient is very young. 2, because and have a very good performance status. 2, we have FOLFIRINOX showing excellent data in terms of survival in the adjuvant and metastatic setting, though it was not seen in the PRIOPANC-2 trial. 3, it is pancreas most of the time when it fails, it is failing systemically rather than locally. And 4, I would like to go with chemotherapy. Why? Because most of our surgeons are not comfortable having operating after neoadjuvant chemo-RT.
Okay. You would choose FOLFIRINOX?
I would choose FOLFIRINOX.
Would Gem-Nab-Pacli be a reasonable alternative?
Yeah, we have in the neoadjuvant setting, we have data with FOLFIRINOX comparing with Gem-Nab-Paclitaxel showing similar survival. But that too, if we extrapolate the data of the adjuvant and metastatic setting, FOLFIRINOX is far better than Gem-Nab-Paclitaxel. We would consider this based on the patient's age and performance status, whether he'll tolerate it or not. That is the main take of this, whether to consider Gem-Nab-Pacli or FOLFIRINOX.
Okay. So relatively, FOLFIRINOX is a more toxic regimen, so hence you would use it for younger patients with good performance status, and probably with the borderline PS, you might use Gem-Nab-Pacli as an alternative.
That's correct.
Okay. So this is the PRIOPANC-2 trial, which actually compared these 2 approaches, where the FOLFIRINOX was compared with Gem-based chemoradiation, and you have that actually Gem-based chemoradiation is almost as good as FOLFIRINOX. This is the most recent data that we have, which compares these 2 approaches. The survival is almost the same. There was no difference whether it was in the resected group. So obviously the resected group always does better, but in the resected group, again, whether you give for chemo alone or chemoradiation, there was no difference. To Jacob, from the radiation point of view, what is our counter argument? So they prefer neoadjuvant chemo. They have certain concerns that surgeons might not be comfortable after radiation. So, and data-wise, we don't have anything to suggest that chemoradiation is inferior to neoadjuvant chemo.
So, this case, patient might require neoadjuvant chemo-RT as part of the TNT regimen if you proceed like that.
No, my question is, as a borderline resectable, can you use only neoadjuvant chemoradiation as an alternative?
That was a standard earlier. So,
so we have the PRIOPANC trial, which has shown that we have the PRIOPANC-2 trial, both showing that chemoradiation is definitely better than upfront surgery, as good as neoadjuvant chemotherapy.
Yes, yes. But in this case, the CA 19-9 was too high. It was more than 1000. So
That was just a scenario that sir showed. For this patient, CA99 was normal.
Okay, then should be chemo first, followed by.
So you won't go ahead with only neoadjuvant chemoradiation?
Likely, yes.
Meaning, so I think generally the dictum now, at least the practice has been that everybody seems to start off with neoadjuvant chemotherapy thinking it is a systemic disease. But I think so like sir said, it's not purely a borderline resectable, it's almost bordering on locally advanced.
Yes.
So probably you would prefer still neoadjuvant chemotherapy.
Go for chemo, then reassess. If there is insufficient response, we'll go for chemo.
Any specific schedule, what technique or what, this is the concurrent chemotherapy of choice that you would?
RT schedule will be at least 50, roughly about 50 grain, 25 to 28 fractions. Conventional fractionation, preferably with IMRT technique to preserve the OARs. Then concurrent chemotherapy, my choice will be oral capecitabine or 5FU, mostly capecitabine. Then in this case, mostly I will go for conventional.
Gemcitabine is also a reasonably good concurrent chemotherapy regimen.
The traditional one is chemo. We have more.
Yeah, so I think if you have used FOLFIRINOX, then I think generally everybody would add in.
I think the ideal companion with RT is capecitabine.
Capecitabine.
Yes.
Okay. Again, why not SBRT in this case? Would you think as an option, or it should be only conventional?
See, RT for pancreas should be a very tricky decision. We should very meticulously select the patients, because if we can sometimes end up in trouble, especially if the duodenum is very close by. In this case, duodenum was a little away, so SBRT is also an option. The main advantage of SBRT is that it's very easy to integrate with the chemotherapy. So the pre-op-panc too, if you see that the chemo RT arm was so long, and it might prolong the definitive surgery. So SBRT will be much more easier to deliver. This case would be an SBRT will also be an equal, but it's after all the take of the radiation oncologist, because it depends on the system, how well we can localize the disease, all those things.
So from a practical, I think from a practice point of view, I think generally everybody would start off with systemic treatment, because generally you want to address the occult distant mets first, which is the most important factor for a patient's final prognosis. Probably bring about some control and then add in a local therapy and then proceed for reassessment and surgery. So I think for this patient also we have done the same. She was started on FOLFIRINOX, completed 6 cycles, tolerated reasonably well. I think we have got comfortable with now using FOLFIRINOX compared to the early toxicities. We know how to modify the dose and anticipate the issues. The reassessment CT showed there was moderate reduction, no new lesions were noted. The next, so this was the image. We have there is a mild reduction. There is but the contact is still there with the SMA and the SMV. And as Jacob had emphasized, the radiation, and sir had emphasized the radiation, either in whichever form, in some form, either SBRT or conventional radiation form, is important to definitely bring about resectability status and get to you an R0 resection for the pancreatic tumor. So I think we are a little bit running short of time, so I'll just quickly go through and maybe finish off with the important aspects. So the optimal neoadjuvant approach is what we have discussed. This is something that has recently come with the total neoadjuvant chemoradiation, where there was this was a slightly surprising result where RT did not add benefit. But again, if you see the subgroup analysis showed that the patients who received chemo, among the patients who underwent surgery, it was the chemoradiation arm which drastically did better, with a median overall survival of almost 48 months, which is almost double to what we consistently see. The Alliance trial is also something that we have shown that adding SBRT after FOLFIRINOX. There are a lot of criticisms to this trial which showed a detrimental result with SBRT. Again, with regard to the randomization point, the more aggressive disease probably that is being, but again we knew that there are better pathological response when RT is being added, and among the patients undergoing surgery there is a good reasonable overall survival. So SBRT, like Jacob emphasized, it is very easy to incorporate with the systemic treatment, with minimizing the interruptions of systemic treatment. This is again something from our Indian experience. Reena and Rahul's team from Tata have recently presented their paper where they are using 40 to 45 gray with SBRT and showing that it is showing good results and good local control. From target volume delineation, is there something that you would like to add on, Jacob? Or sir also could?
We would usually include both the GTV and the nodal regions, definitely. Okay. The high-risk areas will definitely be included, including the celiac axis, the mesenteric artery, the duodenal artery, all those parts, and the high risk, the Baltimore Triangle area will definitely be included. Basically, we contour the vessels with a margin and then expand the margins to include the triangle so that the nodal areas are adequately included.
Okay.
If,
Sir,
if it is in the conventional fractionation.
So do you routinely do elective nodal irradiation? Because there is two philosophies of not doing elective nodal irradiation, as well as especially people who are proponents of SBRT, they feel it is the tumor vessel interface which is the most important part.
No, although, but it is always better to include the nodal area. And we have the RTOG consensus also for the contouring. So if you don't have an even expansion of the vessels, so you have to take a 2 to 2.5 centimeter expansion for the SMA, the celiac axis, and the aorta. You have this is at least for the PGs. You have to expand 1 centimeter to the left side, whereas onto the right side you have to expand 2.5 to 3 centimeters, 2.5 centimeters, and anteriorly 2.5 to 3 centimeters to include the nodes. So that's how it should be. The nodes should be included.
So I think this is two guidelines that recently have come, the ISTRO and the SBRT contouring guidelines, where again elective nodal irradiation, different institutions have different practices. There are certain centers who don't practice external elective nodal irradiation at all, the tumor vessel interface, and again motion management is also something that you need to take into consideration when contouring for pancreatic cancer. The Baltimore Triangle is something that has come up recently, where the Johns Hopkins Center has shown that among the non-RT or operated area, the most common site of local recurrences was in this triangular area around the vessels, including the arteries and the veins. And probably in the newer guideline where they are doing an RTOG Atlas has slightly modified it, where they feel that even if you're not doing elective nodal irradiation, but your volumes need to be slightly larger, and they have this concept of a low dose CTV to account for this movement. So every fractionation regimen, 25 or 15 or 5 fraction schedules, you have a low dose volume also, low risk volume like you have in head and neck malignancies. So this patient received 50 to 55 gray in 25 fractions after the 6 cycles of chemotherapy along with concurrent capecitabine. A reassessment CT was done. There was further reduction from that 4 centimeter lesion which had gradually reduced after FOLFIRINOX. It has now reduced to a 1.5 to 1.5 centimeter. Again, still having contact maintained on the CT with the posterior aspect of the SMV and SMV. So this is the current thing. Now, Sharat sir, for now the next question. Now, after the neogen treatment, they'll be referring the patient to you to decide is this patient amenable for surgery.
So usually after radiation, the imaging, we need to do the CT that is already being done, and what we look into is not to have any progression of the disease. Rather than it's very rare. In this particular patient, we have a response from 4.7 centimeters to 2.5 centimeters, well and good. But most of the patients, we don't get such a response. So what we are looking into is progression of the disease. If there is some progression of the disease at the nodal station,
stable disease and
stable disease,
partial response is good
and
enough.
CA99 values are also important. Okay. When you have a reduction, in this case it is normal, less than 50% reduction, it is a good prognostic factor. And also when there is a complete normalization, then also we have great resectability. Okay. If you have a progression of CA99, then R0 resection is not possible most of the time.
And in short, what would be the surgery that you would actually do for this patient?
Go ahead with the classical Whipple's procedure, but here we may have to resect the vein. That should be planned properly. The CT image initially gives you the idea where and at what segment is to be resected. It is difficult to resect the lower segments of the portal vein below the confluence. After the portal vein formation or before the portal vein formation, it is difficult. And above, we can have multiple resection. You can put a graft, you can put a patch, you can almost resect up to 1 to 2 centimeters of the portal vein and put a graft over there.
Okay. So you have to be ready for a vascular resection as well.
The point is the vascular resection will be considered on the first CT scan that we do, triple phase CT scan.
Okay.
So for the post-chemo, post-neoadjuvant chemo RT cases, will you consider desmoplastic reaction in this sort of imaging findings? And will an MRI will be much more useful?
We have this flappy PET and other imaging modality. There comes the importance of all those PET scan images. We may add a PET scan also, a pre-chemo RT PET scan and a post-chemo RT PET scan to see, because the tumor has a different type of microenvironment, pancreatic tumors especially. So that periphery of delineation may be better, but flappy PET is little costly, coming around 35 to 40.
What we do during the RT part is that we can give a differential dose along the vascular, that interface area. So there might be a chance of desmoplastic reaction that might.
I think what sir is trying to say is you only have the imaging in front of you right now to take a decision. So you have to go prepared inside. If inside you feel it is coming off and it's just fibrosis or just
the point there is near final HPR, if the vein is definitely infiltrated, your prognosis is bad. So that we cannot make out with any investigative modalities.
So I think generally introp assessment and redefining your extent of surgery is also an important.
So in this case, will you proceed with a diagnostic laparoscopy followed by the proper procedure, or directly going from?
Diagnostic laparoscopy can be done because we are done so much of treatment and we don't know exactly micrometastatic disease. Yes. It is usually done.
So this patient, again, it was decided now MDT to go ahead with exploration in this. This patient, when it went inside, the surgeon felt the tumor was slightly adherent, but however the plane could be easily developed and they get dissected off. So they didn't really do a vascular resection and reconstruction. The final histopath actually showed a very good response. There was no malignancy in the pancreas. There was a duodenal wall infiltration which had residual atypical glands. It was a good response. All the margins, the SMA, SMV, pancreatic resection margin and the CBD margins were all free. So this is one of those rare scenarios where we have a very good response to treatment. Just to finish off this patient, post-operative therapy, is there anything that you would offer, Amita? Now they have done the treatment. There's a very good response. We have finished our neoadjuvant chemo. Anything?
Yeah, just the same. We will complete the FOLFIRINOX regimen up to 12 cycles. That is
12 cycles. Okay. So I think 2 cycles, because this patient received concurrent chemo radiation, I think they proceeded till 10 cycles of FOLFIRINOX for this specific patient. But suppose, like she said, if the patient has not received radiation neoadjuvant, would you think of giving post-op RT, and when would you want to add post-op RT?
That is one situation to add post-op RT is positive margins and positive lymph node metastasis. Then we'll go for conventional post-op chemo RT.
So margin positive and node positive, multiple node positive.
Yes, that will be an indication even in if the patient goes for upfront surgery also.
Okay. So I think we have just slowly run out of time. So I think quickly just the LAPC will just focus on this. This is a similar kind of scenario which has extensive vascular arterial involvement encasing the SMA almost 360 degree. This patient again, so there's no debate on, I think this patient requires a chemotherapy regimen. Again, after 6 cycles of chemotherapy, patient was reassessed, stable disease. We considered adding local therapy. Is local therapy always warranted? Because the recent ESMO guidelines actually doesn't add RT as an option in locally advanced. They feel only chemotherapy alone is good enough after the some of the evidences that they have quoted. But I think from it might not change the overall survival of the patient, but I think there are a lot of other benefits, especially with regard to local control, that radiation will add. And I think this patient received radiation as well, 50 to 55 gray with concurrent chemotherapy. There was a moderate reduction. There is slight reduction. Especially the SMA you can see, which was 360 degrees, now kind of free. The thickening around the other vessels also have receded, and the patient completed the chemotherapy. Maintenance chemo, would you consider in this patient? Patient is considered unresectable. You have finished neoadjuvant. Amita, would you think of, you have completed your full course of FOLFIRINOX. This particular patient, would you keep the patient on maintenance, any therapy?
For maintenance, we have no data to have capecitabine maintenance, but pertaining to the fact that the patient is going to relapse very soon, we may consider having maintenance for this patient.
Will there be any advantage for doing molecular testing for this case if it was done earlier? So that might help.
If it is inoperable and we can have a genetic testing at that point of time to consider if olaparib can be given or not.
Okay. So in locally advanced unresectable disease as well, radiation has a significant role to add as a consolidation. It should not replace a multi-agent systemic treatment. There is doubtful discussions on whether there is actually PFS or OS important improvement, but there are certain meaningful endpoints like quality of life, local regional control, which actually radiation will have a significant improvement, and actually 20 to 30% of these cases might actually become resectable, which is the most important endpoint that we should look at. With regard to pancreas. This is the recent CONCO trial which sir also touched upon, the recent one, which shows that there is no difference in the outcomes but survival, but definitely from the local regional control point of view there is a significant benefit when radiation is added. Last point to be discussed, is there some role for surgery in such case scenarios as well? Because I think surgery is also evolving with major vascular resections coming into play. So is there arterial, even if it is encasing an artery, can you still do an arterial resection and vascular reconstruction?
We are dealing with a disease which gives you overall survival of less than 20%. 70% is what is overall survival. Taking it further on a unresectable or a locally advanced disease, maybe a 10 to 12% overall survival is what we are going to gain. But in a high volume center, maybe more than 17 cases a year. Like Tata Memorial Hospital, where they do 50 and 100 cases per year, they are attempting resections, but what data shows that whenever the artery is involved, it doesn't give you survival benefits. So the procedures they have done is, when the celiac axis is more involved rather than the lower part SMA, they do their procedures there. Also there is a chronic vein, if it is fully encased and even going into the posterior part, they have resected the vein and kept it like that. That is a complete vein resection. Short segment SMA resections have also been attempted. The last procedure is apple bye procedure. This is what has done when the celiac axis is fully encased by the tumor. You can take the complete celiac axis and only the ligated celiac axis is seen. You will connect the aorta with the common hepatic artery for hepatic vascularity. This is done, but the results are no long-term data and no long-term trials to give you survival advantage in this kind of resections.
Okay. So again, it's a morbid surgery. With caution, in very high volume experienced hands, it might add some value. So patient selection is very important, not to be extrapolated to all patients. So I think this ends our discussion on CA pancreas. There are a few ongoing trials which is probably of interest. The dose escalation, SBRT versus chemoradiation, there's no trial answering that question, which is all ongoing. So in conclusion, the pancreatic cancer treatment has to be a multimodality approach. Appropriate patient selection is of the most important. Appropriate classification with the help of maybe even a radiologist who's because the radiologist was not there, Sharat volunteered to take up that discussion, but I think you need to have a good rapport with your radiologist and have the right classification on the resectability. The optimal neoadjuvant approach, at least right now, what seems to be working is start with systemic treatment to address the occult systemic mets, add on a local therapy in the form of radiation for local control, and then reassess for a curative intent R0 resection. The surgical assessment, like Jacob also pointed out, a lot of times you might see something on the CT, but many times it might be just desmoplastic fibrosis. You might be able to get away with an R0 resection. So intra-op assessment and exploration is also an important, and not only the scan findings per se. And therefore a multidisciplinary team like ours here is what will ensure the best outcomes for this patient. Thank you.
Thank you.
Thank you very much, everyone, for an engaging session. I now request Dr. Roshni S., Additional Professor, RCC Trivandrum, to hand over a token of appreciation to Dr. Haridas. Thank you, ma'am. I now request Dr. Jaume Rafael, Head of the Department, Radiation Oncology, Amla Institute of Medical Sciences, to hand over mementos to our panelists. Thank you, everyone. Our next session is a Dr. R. Mahadevan Memorial Oration, which is happening in Hall A. I request everyone to proceed to Hall A for the oration, and further sessions will commence in Hall B at 3:40 p.m. I request everyone to please return to the hall as we are beginning the scientific sessions shortly. For our next session on choosing among the many roads to cure for localized rectal cancer, I invite Dr. Arun Shankar S., Additional Professor, RCC Trivandrum. And to chair the session, I invite Dr. Ansar Suhad Sey, Consultant, District Hospital, Nidmangad.
Okay. I would like to welcome Dr. Arun Shankar, Additional Professor of Regional Cancer Center, Radiation Oncology Department, for choosing among the many routes to cure the localized rectal cancer. It's a rapidly changing field in the field of surgery, the chemotherapy, and neoadjuvant concurrent chemotherapy has evolved like anything. So he will enlighten us about the recent trends.
Thank you, respected chair and dear friends. Good afternoon. So, about a decade ago, it was very easy for us. We just had these two. It was easy to choose. When a patient comes in front of you, you would need to decide whether you need to give neoadjuvant radiation, neoadjuvant treatment or not. And then, if it is a neoadjuvant, if you decide for neoadjuvant treatment, then the question was whether you need to give long course chemoradiation or a short course chemoradiation. You had just two choices there if you decide to go for a neoadjuvant treatment. It was that easy. Now you have so many roads, you really don't know which way to go. You are confused, and after reading, everyone would be confused. So when we sit in front of a patient, everybody has a different viewpoint. Madong would see the reports, he sees the patient from the front and has an opinion on that. We see the profile, we see the images, black and whites, and then we have our own opinion. And then there is a surgeon who does the actual per-rectal examination and has an opinion on his own. Whether our opinions concur or not is a question that needs to be decided. So in an MDT, we would need all three to decide whether the optimal way to go for each patient. So like I said, there are too many options now. Earlier it was these four: NACT-RTA surgery, and then if it is a short course early surgery, short course delayed surgery. And for an occasional patient who came to you after surgery, then the question was whether you should give post-op RT or not. Now, why do we have so many other options? Basically because if there is a good road that is wide and smooth, then nobody would think of alternate roads. But when that road is not smooth or has obstructions or complications, then you would look at other alternatives. So these treatment options had its own issues. Patients who undergo surgery many of them would need to have stomas, permanent stomas that affects their quality of life, physical functioning, and etc. And then you have radiation, which adds to other complications, infertility, pelvic fractures, and a lot. So people started looking at options, de-escalation options, whether you need surgery or not, whether you need radiation or not, that is surgery alone options, chemo surgery alone options, and then whether you can avoid surgery as such, the accidental wait and watch, then the intentional wait and watch, that is you intend to do a wait and watch study, and that sort. And on the other side, you had a set of patients who, in spite of all your treatment, used to fail. And for them, you needed doses, some sort of escalation in your treatment. So the TNT protocols came into existence. So we'll need to choose among these which way to go. For that, the basic dictum is that you need to have a quality assured basic imaging. So the most important thing is MRI pelvis. You would all know what are the importance of why we need a MRI pelvis over a CT scan. These are the usual factors that we all discuss each and every time. Peritoneal involvement, sphincter involvement, EMVI, tumor deposits, MRF, everything. 2 points that I would like you to remember is that these MRI is not able to distinguish properly between a T1 and a T2 lesion, okay? And it also tends to overstage T2 lesions. So what is actually a T2, it may show as a T3A or a T3B. So not all T3A and Bs that you see in an MRI is a T3, it could be a T2 as well. Endoscopic ultrasound could help you in these situations. If MR is contraindicated for any reason, then endoscopic ultrasound is your go-to investigation, especially for an early disease. And then if you want to distinguish between T1 and T2 or between T2 and a T3A and B, then endoscopic ultrasound may help you in this aspect. The only problem is that it is operator dependent, it has a small field of vision, and the resolution posteriorly is a bit limited, and it cannot see the lymph nodes. So, and the other point that, other than the classical teaching that we need to be careful about is what is a T4A and what is an MRF positive. This is because this is one area that people usually confuse with. That is why I thought I might stress here. So this is the rectum, and here this is the peritoneal lining. Here it comes and dips anteriorly much lower here, and posteriorly it is much higher up at the sigmoid takeoff. So here you have a anterior peritoneal reflection or the serosa here, and so if there is disease involvement in anteriorly, it becomes T4A. Where you have serosa, you don't generally call it as MRF positive, you call it as T4A. MRF positive is only in the where you don't have the peritoneal lining or the serosa. So here this is the sigmoid, and coming down the sigmoid takeoff and further down. And here, if you have disease that is involving anteriorly, if it involves the serosa here, it is T4A. You don't call it as MRF positive. MRF positive only happens posteriorly here. In this section that is much lower down, very close to the anal canal, here you can have a MRF positivity in all directions, but otherwise you generally don't have. So you need to differentiate between T4A and MRF positivity. And MRF is considered positive if the margin is less than 1 mm, either by a primary tumor or by an EMVI, or if there is an irregular enlarged lymph node. A smooth round lymph node, even if it is sitting very close to the MRF, is not generally considered as MRF positive. So this is EMVI. There are 4 grades. That is extramural vascular invasion. There are 4 grades, but 0 to 2 is not considered positive, and only 3 to 4 is considered as EMVI positive. And you all know the significance of EMVI. And then the lymph node significance criteria. All lymph nodes that you see are not significant. You should stage properly, not just with the size alone, but other characteristics like the shape, the regularity, and all of those as well. So like I said, the general whole paradigm was much easier. Early disease, especially if it is higher up in the upper rectum, single modality surgery was okay. Intermediate, you go for either, if you need to reduce local recurrence, you can give either neoadjuvant short course RT or a long course chemoradiation. And if it is a very bulky disease, then you would give preference for a chemoradiation over the short course. And if it is short course, it is short course and delayed. And if it is an ugly, you obviously would need to have all three, that is chemoradiation, surgery, and mostly adjuvant chemotherapy as well. But now this is a new paradigm. In early disease, you have options of chemoradiation and limited surgery, or a wait and watch. And you can use contact brachytherapy alone or after chemoradiation. And then in the intermediate, nowadays people tend to combine together the early and the intermediate and keep the ugly as a separate one. In the intermediate, you have surgery and chemo, or surgery alone, especially if it is upper rectal lesions. And then you have chemoradiation. And if CR, patient may be kept on watch and wait as well. In ugly, like I said before, all three modalities in as in TNT. That's a total neoadjuvant therapy. So de-escalation, you can avoid surgery or go for a limited resection. You may avoid radiation and you may avoid chemotherapy. These are the options that we consider. So coming to the non-surgical approaches where you try and see not to do surgery, what is the rationale for this is that patients who achieve complete response, surgery may not improve the local control much more than that, and surgery is probably unnecessary. And these patients are probably have a good biology and have a low risk of recurrence. And you can avoid the morbidity of surgery and improve the quality of life. These are all proven. And the post chemoradiation evaluation consists of three components: the digital rectal examination, the MRI, and the endoscopy. So the basis of this was the old study from Haber-Gamma way back in 2004, where they showed that 27% of patients go in for CCR, and in patients who underwent surgery, and an additional 8% is having PCR. And if all these patients had gone in for surgery, 72% of them would have had stoma. So that is, you are saving these patients from having a permanent stoma. And the recurrence rate is also quite low, and if it happens, it's usually luminal. Obviously, due to the paucity of time, I'll not be going through all of these studies, but selected few. And this is one study that you need to look into. That is the OPERA study, organ preservation by either the TNT approach. You don't say TNT because you are not obviously going for surgery in all of them. So here you have two approaches. Either you go for chemoradiation upfront, followed by chemo, consolidation chemo, and if CR, patient goes in for watch and wait. And the other group is patients undergo chemo first, followed by chemoradiation, and then go in for, if CR, they go in for watch and wait. The watch and wait, the patients who undergo a complete clinical response and they who undergo watch and wait is much more, to the tune of around 60% in patients who undergo chemoradiation upfront, as opposed to the chemo upfront, where the rate is around 40%. And regrowth happens in about quarter of these patients who undergo watch and wait, 22% in patients who achieve complete response. But if the patient has had only a near complete response, then almost half of them do relapse or recur. So you need to be careful when you follow up these patients. The second is the contact brachy boost trial, that's the OPERA, where there are two sets of patients. One, the standard arm had chemoradiation, wherein the chemoradiation was up to 54 to 54 gray. And the other arm had two sets, that is one who underwent chemoradiation followed by a contact brachy boost of 3 fractions of 30 gray, so that is 90 gray. and the other arm, which had small lesions less than 3 centimeters, they underwent contact brachyphysis followed by chemoradiation. You can see that the complete response rate, or the patients who could be taken up for watch and wait, and that who had an organ preservation, that is up to 80% in the contact brachy arm, as compared to around 60% in the standard chemoradiation arm. So even if one thing that you should look at it this way: if you have only chemoradiation, you can still, if you go up to 54 gray, you can still save those patients from a surgery in almost 60% of them. If you have contact brachy, good enough. You can improve the non-surgical rates up to 80%. But even if you don't have, you're still okay. In 60%, you can still avoid surgery. This is the other study. This is a Star Trek study. It has come only as an abstract in the ESTO 2025. Here you had the standard surgery, patients T1 to T3B, and standard arm had standard surgery. The other had an organ preservation arm, that is chemoradiation of 50 gray, followed by watch and wait, and the other had a short course RT 5x5 and a watch and wait. The finding is that at 1 year, 80% of the patients who received long course chemoradiation, as compared to 61% in those who received short course RT, did not undergo radical surgery. So if your approach is intentional watch and wait, you should probably be doing long course chemoradiation rather than a short course RT. So this we did. At what point will you assess these patients once a patient undergoes chemoradiation? Various trials have different time points of assessment, but generally after chemoradiation or after radiation, whatever is the modality that you use, around 8 to 12 weeks is the time when you should be doing your first assessment. And the second assessment should be between 16 and 20 weeks. So that is the time by which usually your chemotherapy as well gets completed. So it has 3 modalities, and if at 20 weeks the patient do not have a complete response, then the patient should ideally go in for a salvage surgery. So the patient should have a digital rectal examination, an endoscopy. Do you need a biopsy? You don't. Biopsy does not improve the diagnostic accuracy. It often leads to high false negative rates as well. So biopsy is not recommended. And there are various gradings for endoscopic assessment as well. And then you have the MRI. You should be using both the T2 weighted sequences as well as diffusion weighted and ADC maps to look at it. You should be comparing with the previous images, the baseline images as well, to finally reach a conclusion whether the patient is in CR or not. So now let's look at schedules where you can avoid RT. This is the famous prospect study that came from US, wherein patient underwent either long course chemoradiation followed by TME, or underwent a neoadjuvant chemo, and in good responders they avoided surgery, and in the bad respond or patients who did not have a good response, they went in for long course chemoradiation. It did show a nearly equal disease-free survival, and so in patients who are at low risk, they may undergo chemo followed by surgery. But you should look at the prospect study in another way as well. The prospect study had a very stringent QA process. The surgeons who could do the surgery was credentialed. Not everybody could just go in and be part of the prospect study. They had to have 10 operative reports, associated pathology reports to show that they are actually doing a good TME. Similarly, the radiology had a central review, and the radiotherapy was also quality assured. So in this setting, when you have an extremely quality assured setting, prospect study, or the way prospect study is done, you can apply to your patients. But otherwise, be careful. The main criticisms of the prospect study is that half of these patients had a very early stage disease, and they probably never had any benefit with either RT or chemo. So a wrong patient population was there, and hence if you have a large number of patients in both the arms who actually did not require either chemo nor surgery, then, and if you look at the non-inferiority, they would obviously be non-inferior, the study. So the study is not actually a good one. And over-treatment persists. Instead of RT, you are compensating with chemotherapy. You just shift from RT to chemo. You are not reducing the burden of treatment. And then they had wrong analysis plan, change of goals midway, and a lot of other issues. So be careful when you use prospect study. You should have a similar quality assured environment when you are using prospect. And second study where radiation was avoided, that is a FOWAC study, where you had 3 arms. RT arm 40 to 50 gray was given, then you had FOLFOX plus RT arm, and then there was a FOLFOX alone arm. They said that the results are equal and that there is no difference between FOLFOX or FOLFOX plus RT alone arm. But if you look at the fine print, the FOLFOX 6 group alone, they had the liberty of addition of radiation either before or after surgery at the physician's discretion, and that was mainly for patients with MRF positive or a T4 disease. And if you look at that subgroup of patients in the FOLFOX alone arm, almost 30% had T4 disease and 31% had MRF positivity. So again, it is not actually a comparison of truly between FOLFOX RT and FOLFOX arm, and they have not specifically mentioned how many in the FOLFOX alone arm received RT. So again, for FOWAC study, you should review, you should learn with caution, you should not accept the results as such. Many patients in the chemo alone arm also received RT. So this is the results of the FOWAC arm, which shows nearly equal results, but the local recurrence is slightly less in the study arm, which received in whom RT was given to all the patients. That's a FOLFOX RT arm. So surgery first with no neoadjuvants, no surgery, no RT, no chemo. It can be given by an experienced and dedicated team of radiologists who do a good MRI, surgeons who do a proper TME, and a pathologist who would assure you that the TME is complete. In them, in patients who have lesions in the upper rectum, T1, T2, N0 or not positive, you can do. T3, N0 or not plus, that is N1 probably, you may, especially in the upper rectum, they can undergo surgery. And in the middle and the lower rectum, use very cautiously, that is surgery alone should be used cautiously only in T1 or T2 N0, probably in an early N positive disease as well. But in T3 N0 and others, you should use with caution alone. So this is the Occam study where patients who are at high risk for that is MRF positive, T4 or T3 MRF negative in the lower rectum. These are the patients who are at high risk for local recurrence. They underwent chemoradiation and surgery, but all other patients underwent primary surgery. And they did show that the local recurrence, when you select the patients, the local recurrence is quite low, that is only about less than 4%. So again, in a quality assured setting, where you have a good team, you can probably avoid radiation or chemo in a significant number of patients, but be careful when you do that. And this is another study from the Dutch, that's a Dutch cohort study where they evaluated patients who underwent treatment between from 2000 at 2 groups, that is 2011 and the 2016 group. The 2011 group had almost 80% of the patients receiving RT, whereas in 2016 dropped down to half, that is around 37%. But their local recurrence rate remained the same. The overall survival improved a little more. So attesting to the fact that again, if you have a good setting, you can probably avoid RT in a significant number of them rather than the way we do when most patients would receive RT. So coming to the next setting, that is, now this is where we de-escalated, now we escalate the treatment. I thought I'll just give you all studies together. I don't know whether you'll be able to see it. In general, all these TNT studies were able to improve the disease-free survival and the PCR rates. Unfortunately, there are only 2 studies that showed improvement in the overall survival. When you are treating these patients in the curative setting, you would basically be looking at the overall survival, not just at the disease-free survival alone. But there are only 2 studies that showed improvement in the overall survival, that is the PRODIGE and the STELLA study. Now this is the PRODIGE study. In the PRODUCE study, they gave, in the experimental arm, they gave FOLFIRINOX into 6, followed by chemoradiation, followed by surgery, and FOLFOX into 6. So that was the experimental arm. And if you look at overall survival, this is 12 months. Even before that, there is a significant dip in the overall survival in the standard arm. So these patients, that is even before 6 months. So these patients died, that many number of patients died even before they reached 6 months. The survival they would have started evaluating the survival when they're randomized. So even before they completed 6 months, that they haven't even completed the whole treatment. Even before that, there is significant fall in the overall survival there in the standard arm. This is not something that you expect from a TNT study. So this sort of early mortality was never seen in any of the other TNT studies. And the effect of chemotherapy, if at all, that is usually evident only by 1 to 1.5 years. And if you see that once this fall occurs, it is almost parallel. So if this fall had not occurred, then these lines would have probably overlapped each other. So is there a confounding factor to it? We really don't know. This was just one study that was significant, and many have started using FOLFIRINOX as a standard, but you should be careful about this as well. And regarding the STELLA study, this is another study that showed overall survival benefit. But again, when they looked in, the study was basically looking into the disease-free survival and it was a non-inferiority study powered at 3 years. The DFS actually showed no difference. The relapse rates were also similar. So when the DFS is similar, how can when they did an overall survival, there was a significant difference in overall survival. This again defies any logic and explanation. Without any obvious reason, why did the overall survival alone improve without any change in the disease-free survival? So again, that brings STELLAR trial also into the doubt. So TNT improved the PCR rates, partly contributed by the delay from RT to surgery, not purely because of chemotherapy. You know that as a time from RT to the surgery increases almost up to 16 weeks or 12 to 16 weeks, there is an improvement, change in the PCR rates as well. It may provide a DFS benefit, but the overall survival benefit is doubtful. In the Rapido study, we all know there was a slight local regional recurrence that was significantly higher than that you would expect in the standard arm. And the only thing is, in the OPERA study, in the wait and watch arm, we could have at least 50% of the patients in them. So that is one good grace about TNT. Not TNT, having chemoradiation and chemo upfront, that is probably we can put 50% of the patients in the watch and wait. So I'll just summarize with the ESTRO guidelines. T1, N0 or N1 patient, especially in the upper rectum, it can go in for a primary surgery. And adjuvant chemo only if the surgery shows these factors, T4, N+, EMVI or deposits, or after NACTRT, if the node is positive, EMVI and deposits. That is when there is a conclusive evidence that adjuvant chemo benefits, otherwise there is no significant evidence of benefit, survival benefit with adjuvant chemo. And T2, N0 or T3, N+, you can either go in for primary surgery if the risk is low, margins are clear, or you can go in for prospect study like FOLFOX or CAPOX followed by surgery. Or this arm was not there in the ESMO. This is one thing that I have added. You can still give neoadjuvant chemoradiation followed by surgery, especially if it is a T3, C, D, EMVI or an N2 is present. But if there is EMVI and N2, you'd probably put those patients as high risk as well. And in T4 disease, you go for neoadjuvant chemo followed by surgery, or more option, ideally TNT or a chemoradiation followed by surgery and adjuvant chemotherapy. TME, upfront TME is something that you generally wouldn't rarely consider. And localized rectal cancer in the lower and middle third. And if surgery is being considered, there are two options. Either you consider surgery or you don't consider surgery upfront. If surgery is considered, then T1N0 surgery upfront, T1N plus or a T2N0, you can again go for surgery upfront. But if it is not positive, T2 not positive, T3 or N1, you should be giving neoadjuvant treatment. Either if the margins are very clear, then you may consider neoadjuvant chemo, but again cautiously. More common choice would be neoadjuvant chemo, either short course or a long course chemo radiation, or you can even consider TNT. And proceed with surgery since surgery is intended. And if we are thinking in terms of avoiding surgery in any case, then you should either give short course RT or long course chemo radiation. And if it is an early disease, you can give either preferably give long course chemo radiation, or alternatively short course as well, and then reassess brachy if feasible. Otherwise, especially if it is a lower rectum, you would can think of brachy and go for watch and wait. And if it is high risk disease, you'd go for a TNT, and then that is an accidental watch and wait. So you generally, with a higher risk tumor, the chance of a complete regression is less as compared to an early disease. So, but still, if patient goes in for a complete response, you can go for watch and wait. So this is just again the summary of what I said. Thank you.
That was an excellent comprehensive presentation by Dr. Arun. Can we take 2 questions? So I would like to ask, what is the ideal interval between neoadjuvant concurrent chemo RT and surgery, definitive surgery?
Ideally between 2 and 3 months, that is the best way to do it when the fibrosis isn't too much, and then you would get a reasonable response as well. That is when you have decided for chemo radiation for surgery, then at around 2 months.
I have seen some points regarding deposits. Is it acellular mucin deposits or something like that?
Tumor deposits are when it is actually, you look at it as EMVI is when the tumor infiltrates into the vessel and goes in. Sometimes this gets disconnected, and then you don't see a connection between a growth that is there and the tumor through the vessel. So that is when you generally call it as tumor deposits. They have a different characteristic from a lymph node, and tumor deposits have an even worse prognosis than lymph node. It is actually considered as bad as an EMVI.
So nothing to do with acellular mucin deposits?
No.
So any questions from audience?
Just a practical discussion point. I think we have had this discussion. What is the sequencing that you would prefer for TNT? Is it the RT first approach, or would you start with chemotherapy? At least your personal. I know the data doesn't.
I think I'll start sweating now. As the interval from chemoradiation or radiation to surgery increases, the surgeon has more difficulty. So, like in the study that we presented today morning, as fibrosis sets in more, the chance that even a middle rectal lesion or something that was at 5 centimeters or 6 centimeters, that we could have taken for ultra low surgery, that would end up becoming a APR. So that happens when you increase the duration from radiation to surgery. In those patients, probably we should start at when you know that you may probably do LAR or a ultra low resection. If that is possible, then maybe you should look at chemotherapy first and chemoradiation. But if it is a very low lesion,
anyway APR would be required, then
the other option is an APR, and in which case you can definitely go with chemoradiation followed by chemotherapy, and that is better in another way as well, because that results in more patients getting a clinical. This is a discussion that happens with the team. So with our team, this is the discussion that happens. It may be different at other centers, and like I said, if you keep reading, all the guidelines have a different approach across Atlantic.
I think all the TNT trials that you showed are different from each other. There are different regimens, different radiation doses. One more question. During follow-up, suppose you have achieved a CR and then you're keeping the patient on the 3-monthly routine follow-up. What is your trigger point to decide on salvage surgery? Do you need a biopsy proof, or if you see on MRI there is a serially increasing thickness but clinically not palpable, still would you push for surgery, or would you wait for a mucosal lesion to come have a biopsy proof before confirming for a salvage APR?
Thing is, I personally don't have too many patients on watch and wait to say that this many failed and this is the way to go. But from what I've read, you don't need a biopsy to prove that it is positive, because many times it is negative, false negative is quite high. And that's why biopsy is not part of the routine follow-up. And second thing is that none of these are going to be your ultimate answer, because I have had a patient who was in CR and then MRI showed serial increase in thickness, and then PR showed probably some residual disease, probably some increase in thickness there. Patient underwent APR and it was PAT CR. So
I had the same experience with one of my patients. That's why I was kind of.
I think there is some learning experience. Yeah.
So if you're seeing at luminal regrowth or recurrence, what you say technically, then it will be either endoluminal or outside wall. Outside wall increase in the thickness, if it is dark fibrotic, it can happen. That is to be observed. It may get bigger with time, you don't need to worry. But if it is heterogeneous in intensity, right, with the light color, component, then that is disease. You will not feel it, you will not see it on endoscopy. That is external, right? If you have endoluminal, which is 80% of your regrowths, right? So you very less only external component will be there. In that case, endoscopy will show you. Even if you can't feel it, you can see it, right? So that will give you a hint, and you can call for a close follow-up after 8 weeks. Instead of 3 months, you call it after 2 months or 6 to 8 weeks. You repeat, you will see a sequential increase whether in the size or your feeling of finger, and then you can operate. You don't need to biopsy that. Okay.
Shall we wind up the session? Okay.
Thank you, sir, for that concise talk. I request the chairperson, Dr. Ansar Suhad Seir, to hand over a token of appreciation to Dr. Arun. I now request Dr. Francis V. James to hand over a token of appreciation to our chairperson. We are moving on to our lung cancer segment. The first talk is on the optimal selection and sequencing of systemic therapy and radical radiation therapy in locally advanced lung cancer. To chair the session, I invite Dr. Shashindran PR, Head of the Department and Senior Consultant, Radiation Oncology, Baby Memorial Hospital, Calicut, and Dr. Anup R., Associate Professor, Radiation Oncology, Amrita Hospital, onto the stage. I invite Dr. Roshni Shyam, Additional Professor, Regional Cancer Center, Trivandrum, to speak on the topic.
Yeah. This one, right? Yeah. Say it again. Yeah, it's a wide. How do you want it? Yeah, it's fine. Yeah, it's fine. Good afternoon, my dear friends and teachers. So I'm being selected to talk about the optimal selection and sequencing of systemic therapy and radical radiation therapy in locally advanced carcinoma lung. and I have taken the liberty to just stick on to non-small cell lung cancer, but I know that there is, Dr. Swati would be covering small cell lung cancer. And the optimal selection and sequencing, there are different sequencing therapies, as we have already heard from Dr. Arun, that across the globe, there are various sequencing regimens or various sequencing practices which are being done. But from our part of the world, I think it is easier for us to follow the ESMO guidelines, which is very practical and which would actually balance of the health economics in selecting the therapy. So I would be mainly discussing on the ESMO guidelines. This is the recent 9th edition of AGCC, which has proposed, where there is no change in the T stage, but we have an N2 division into N2A and N2B, depending upon single station versus multiple station. They have actually changed this only because the multiple station lymph node, they have found that multiple station lymph node has worse prognosis than single station. So they have divided that. And M1C, they have divided into single organ and multiple organ. So these are the proposed changes in the new AGCC. So practically, the locally advanced lung cancer would be stage 3A, 3B, and 3C. So what is 3A? 3A is late T stage and N0, N1. And early T stage and N2, and 3B would be late T, N2, early T, N3, and 3C would be late T and N3. Altogether, the locally advanced carcinoma lung non-small cell has a 5-year survival of about 20 to 25%, with high risk of recurrence, both metastatic as well as local. And they have actually a distant failure rate of 30 to 50%. They have a wide range only because of the heterogeneity of the population where we are dealing with. And the chance of brain metastasis is very high. And the local failure rate at surgical series even ranges from 15 to 60%. Approximately 1/3 of the patients newly diagnosed would be in 3N2. And these stage 3 would be like, N2 would be like presenting with resectable tumors with occult nodal microscopic metastasis, which you would found only during the surgeries, or to unresectable or bulky multi-station nodal disease. So due to the heterogeneity of this stage 3 non-small cell lung cancer, it has been practically divided into 6 subsets. So subset definition is 3A0 is T3N1 or T4N0N1 without N2. And 3A1 is incidental nodal metastasis, which is found on final pathology examination of the resection specimen, that is not even found intraoperatively. 2 is nodal mets, which is found intraoperatively. And 3 is nodal metastasis, single or multiple station, recognized by pre-thoracotomy staging. It is mediastinoscopy or other nodal biopsy or PET scan. So it was diagnosed pre-thoracotomy. And 4 is bulky or fixed multi-station N2. And 3B is nodal metastasis in the N3 lymph nodes. So these are the practical 5 subsets which are dealing with under 3. So how do you choose the initial therapy? So there are various factors which you would consider when you think about choosing the initial therapy. So first is histology, then obviously the performance status of the patient, presence or absence of driver mutation, which recently had been included in all the guidelines. Previously, we were not thinking about driver mutation in locally advanced lung cancer. It was only in metastatic setting. But now we have to do the testing. And obviously, because of the performance status, the age is also being considered for selecting the initial therapy, and other comorbid conditions, and the concerns and preferences regarding the treatment. So the patient would have preferences, so you have to discuss the options with the patient as well. So it is also the preferences regarding the treatment. So this is the ESMO guidelines, so the management of stage 3 lung cancer. So first, if it is resectable, so this is resectable. So what you do first is you do the after the MDT discussion and everything, you do the EGFR ALK testing and the PD-L1 testing. So if it is EGFR ALK wild type, the 2 categories which you think is whether these patients are chemo eligible or chemo ineligible. So if it is chemo ineligible, you don't have any options. So it is resectable, send the patient for surgery. And after surgery, there are 3 options.
It would be either R0, R1 or R2. R1, R2, you have to discuss in the MDT and decide accordingly. But you know that there is a role for port and stuff in R1 resection. So if it is R0 resection, after surgery, what do you do? So then again, the patient is assessed for whether the patient is eligible for chemotherapy or not. If the patient is eligible for chemotherapy, the patient has to be given adjuvant chemotherapy according to the stage, and then following which, after 4 cycles of chemotherapy, if the patient is PD-L1 positive, then the immunotherapy role came in. That is atezolizumab and pembrolizumab. And if it is chemo ineligible, the patient would be tested PD-L1 positive. There are 2 options. If it is negative, there is only pembro. So, and first, I have talked about patients who are chemo-immuno ineligible the first time. And if it is eligible after surgery, and then you have to actually do neoadjuvant chemo-immuno schedule, because if the patient is eligible for surgery, then if it is potentially resectable, then you can induce a downstaging with chemoimmunotherapy. And after that, you send the patient for surgery. And after surgery, again, like if the patient was given chemoimmuno session in the upfront, that is in the neoadjuvant setting, the immunotherapy would be selected according to the immunotherapy which you had already given in the neoadjuvant setting. The same immunotherapy is given in the adjuvant setting. So when you say surgery, the complete resection necessarily include lobectomy and systematic mediastinal lymph node exploration. So it is always lobectomy plus SMLND. And in selected patients, so if you can't get away with lobectomy, so we can sometimes you have to do a pneumonectomy, and in such cases it must be carried out, but should be adequately selected, and procedure is restricted to the experience center, because the surgical morbidity is very high compared to the lobectomy. So when you have to go for pneumonectomy, so it would be in a center where the expertise is there. This I have discussed, the R1, R2 resection. After R1, R2 resection, the MDT discussion should be done, and incorporation of further treatment. And carboplatin, so when you say chemotherapy, it is always the platinum doublet therapy which you consider. But carboplatin-based regimens can be recommended for patients who are not eligible for cisplatin. And coming to the role of, so I have already discussed about the guidelines which ESMO follows in the area for ALK wild type, and what is the role of is there any role for postoperative radiation in patients with non-small locally advanced non-small cell lung cancer. This was an earlier trial, and where it was like port meta-analysis, which you all know, and there is they have found that for N1 disease it was detrimental, and for N2 patient they had shown that there is an improvement in the survival, but it was not statistically significant. Then came the 2 trials which only addressed port in N2 disease, that is CALGB 9734, port C, and LungArt trial. So this is trials. These are the trials, LungArt, and as I have only 20 minutes, I'll summarize the results of these trials. You have to realize that the LungArt and the PORT-C trials, they have used LINAC-based planning, and they have used CTRT as well as IMRT. And the summary of adjuvant RT is that they have shown no advantage in the disease-free survival, but it has actually shown a decrease in the mediastinal recurrences. So port should not be administered to all N2 patients. So this was the results of all this trial. So would you give, instead of port, would you give post-operative chemo-RT? So this was done in 2 trials, mainly ECOG 3590 and RTOG 9705, and they found that there is no need for post-operative chemo-RT. You can get away with port. So after radiation, after surgery, if the margin is positive, so you have to give post-operative radiotherapy, not post-op chemo-RT. There is no need for that. And what are the indications for adjuvant chemotherapy? So adjuvant chemotherapy, the foci is more than 4 centimeter, presence of LVI, poorly differentiated carcinoma. Now they have included another indication like high SUV in PET, that's more than 10.
These are the adjuvant chemotherapy trials, which I don't know whether you can see. It is the famous IALT trial, the BNT trial, CalGB trial. So most of the trials, actually, they have used platinum therapy, and what combinations can we use in platinum? So the combinations usually they have tried, most of it is vinorelbine, etoposide, vinblastine, mitomycin, ifosfamide, carbo, and vindosin. And the combinations which regularly been used is carbo-vinblastine, carbo-etoposide, and there are trials which have actually tried weekly carbo-pacli as well. And in non-squamous histology, we can actually use carbopemetrexate, but the main agents which had been used in adjuvant therapy is all these drugs along with platinum, so mainly vinblastine, vinorelbine and mitomycin and etoposide. So this is a LACE meta-analysis trial, and after the LACE meta-analysis, adjuvant chemotherapy is accepted as a standard care of patients, for patients with node-positive disease. So this is IALT schema, and this is a famous ANITA study where I have studied observation versus chemotherapy, where they found that there is a beneficial role in adjuvant chemotherapy, where they had used platinum vinorelbine. And after that, so these are the treatment options which were available maybe a few years ago, where you think about even non-small cell lung cancer, there isn't much option in the adjuvant setting. So now there is a role for adjuvant immunotherapy after chemotherapy. So for patients from stage 2 to 3 resected non-small cell lung cancer, which has been already treated with platinum-based chemotherapy, adjuvant checkpoint inhibitors, with choice between the following, then driven by eligibility, because these were addressed in IMpower 1010 and Keynote Trial 091. And coming to the perioperative role of immunotherapy, the perioperative nivolumab has been studied in non-small cell lung cancer along with chemotherapy, and it was published in NEJM. The addition of nivolumab to neoadjuvant chemotherapy results in significantly higher percentage of patients with PATSIA. So perioperatively also there is a role for immunotherapy. And the pathologic response, when they have discussed, when it is Nivo plus IPI, the pathologic response was 32%, but when Nivo IPI was added to chemotherapy, the response was 50%, and at Atazole it was 18%. So these are the NeoStar and the Ford PM et al. And the other LCMC3, but the trials which had addressed these three combinations. So these are different trials. So to sum up, there is a role for perioperative pembrolizumab, which is addressed in Keynote 671, and there is a role for perioperative durvalumab, and there is perioperative nivolumab, and that is addressed in Checkmate 770. But you have to remember that perioperative nivo is not FDA approved, but it is approved in ESMO guidelines, and perioperative toripalimab, that is also not FDA approved, and perioperative tislelizumab, that is also not FDA. The last three are not FDA approved. So adjuvant pembro is an FDA approved drug, which is given after surgery, and platinum-based chemotherapy for patients with a resected NSCLC. But it is addressed in Keynote 091, and there is no role for adjuvant durvalumab in stage 1B to 3A. Atazole, there is a role with a platinum doublet and it is FDA approved for PD-L1 more than 1%. So this is the schema diagram for Keynote 091, and this is a schema diagram from IMpower 010. To sum up, if it is EGFR ALK wild type, if it is chemo ineligible, you have Nivo, which is approved, FDA approved, EMA approved if the PD-L1 score is more than 1%, and Durva, Pembro, tislelizumab, these three not FDA approved, and after which they can send the patient for surgery, followed by adjuvant immuno, depending upon the neoadjuvant immuno which you have selected. So neoadjuvant, in the neoadjuvant setting, you have Checkmate 816, which has used nivolumab, and there is a NeoStar study which has addressed neo plus ipilimumab, and this is, which I have already mentioned, this is a resectable stage 2-3. To sum up, so you have so many immunotherapy options, which is FDA approved and EMA approved. And what is resectability? So you can very well say that T3, according to size, N1 is resectable. So who are the patients who are potentially resectable? So T stages is always depending upon the site, the number, satellite, presence or absence of satellite nodules, and the invasion. So T3 by size and N2 single is potentially resectable. T3 in view of satellite nodules, N1, N2 single is potentially resectable, and T3 by in view of invasion and N1 is potentially resectable. So what is unresectable? Unresectable is T3 by size and N bulky and invasive, and T3 satellite with N2 bulky and invasive, and T3 in view of invasion, N2 bulky and invasive. So what do you do with potentially resectable patients? So potential treatment options are induction chemo followed by surgery plus or minus port, or neoadjuvant CTRT followed by lobectomy, or definitive CTRT. So I have already mentioned about patients with EGFR ALK wild type. So what happens when they have EGFR ALK rearrangements? So after before surgery, that you, if you have the option of getting the EGFR ALK, you would definitely do it. And then if the patient is found to have EGFR or ALK positive, if it is R1, R2, again, it follows MDT discussions and you do accordingly. And if it is R0 resection, if it is exon 19 deletion or L858R deletion, then you have to say whether these patients are chemo eligible or chemo ineligible. If the patient is chemo eligible, then you give chemotherapy, platinum doublet, followed by osimertinib if they have EGFR mutation. And if they are chemo ineligible, also, like no, you can't give chemotherapy, then, but there is an option of giving osimertinib for them for 3 years. So that is what is you have to do when there is EGFR mutation. And if you find that the patient is ALK positive, then again, if the patient has ALK positivity, then after chemotherapy, you have to give, there is data to give alectinib, that is for 2 years. So osimertinib you give for 3 years, alectinib for 2 years. So that is ALINA trial. So this is osimertinib, and the p-value was very significant, and it was like 88% to 78% was the 5-year overall survival. So you have to give adjuvant osimertinib if indicated. So that addresses the ADAURA trial. And adjuvant ALK positive, that is the ALINA trial, that's for 2 years. So that is about adjuvant targeted therapy. So what about neoadjuvant targeted therapy? So for patients with neoadjuvant, patients with EGFR ALK mutated, so we have NeoADAURA. That's that adjuvant was ADAURA, was NeoADAURA, where neoadjuvant osimertinib with or without chemotherapy demonstrated statistically significant improvement in the pathologic response rate, that is 26% versus 2% over chemotherapy alone in patients with resectable EGFR mutated patients. So that is the role of neoadjuvant osimertinib in locally advanced lung cancer. And this all, I'm talking about the resectable lung cancers. So what are the ongoing trials in the adjuvant setting? There are 2 trials, that is Alchemist screening trial and the Alchemist treatment trial. So what does Alchemist screening trial tries? It actually tests the EGFR, whether the patient has EGFR mutation or the patient has ALK mutation. And if the patient has EGFR mutation, they would be allotted to Alchemist treatment trial, where they are given actually erlotinib. So this trial is ongoing. And if they find that the patient is ALK positive, they would be allotted to Alchemist treatment trial in crizotinib. It is not alectinib, it is a crizotinib. So you have multiple options in the treatment trials, groups in the Alchemist trials. So to sum up, so after surgery, arterial resection, if it is EGFR 19 deletion 8858, then if it is chemo ineligible, you have the option of osimertinib for 3 years. If it is ALK rearrangement, if it is chemo eligible, give chemotherapy, platinum doublet, and then give alectinib for 2 years. Coming to the unresectable stage 3 non-small cell lung cancer. So you already have discussed what is unresectable stage 3. So in those patients, again, the things which you do in selecting the treatment is just the same. They first do EGFR, ALK, and PD-L1 testing. And if the EGFR mutation is present and if it is PD-L1 less than 1%, definitely it is unresectable. So you give concurrent chemo-RT, and after concurrent chemo-RT, what do you do? After concurrent chemo-RT, like you have the option of giving maintenance durvalumab in those patients, and in EGFR, this is about EGFR mutant type, and you have the option of giving osimertinib also. And if the patient has PD-L1 less than 1%, so if the patient is not eligible for definitive chemo-RT upfront, you can even try sequential chemo-RT. And if the patients are not even eligible for sequential chemo-RT, then you are done with definitive RT, because if patients cannot be given chemotherapy, you can try radiation, because that's all options you have in hand. But definitely you know that for the resectable, it is definitive chemo-RT is the option. And in EGFR wild type, PD-L1 less than 1%, if the patient is eligible for chemo-RT, then again give chemo-RT. And after which, if there is no progression, I've already discussed, you have to give durvalumab. And if they are ineligible, you can try sequential. And if there is no progression also, if there is no progression after sequential, again you can give the patient durvalumab. So durvalumab is an option in both the situation, where after definitive or sequential. If not, you can try radiation. So therapy for unresectable stage 3 is concurrent or sequential radiotherapy, chemoradiotherapy. And if the patient is not fit for concurrent chemo-RT, sequential or RT alone can be recommended. And in concurrent or sequential platinum-based doublet for 2 to 3 cycles is recommended, preferably cisplatin etoposide or carbopactly. Carbopactly can be given in all histologies, cisplatin pemetrexed in non-squamous histology. And I have already discussed the consolidation therapy. We have targeted therapy, osimertinib in consolidation, and immunodurvalumab. To sum up, EGFR ALK PD-L1 testing should be done in unresectable if they are mutant, EGFR mutant and PD-L1 less than 1%, CTRT if eligible, and if they have EGFR exon 19 deletion or L858 mutation, and there is no progression after chemo-RT, you have to give osimertinib in the maintenance or consolidation. If they're ineligible, then try sequential or RT alone. If it is EGFR wild type and PD-L1 more than 1%, CTRT if eligible. And after, if there is no progression after CTRT, durvalumab for 1 year, and that is FDA approved and EMA approved. EMA has approved it in if PD-L1 TC more than 1%. And in EGFR, PD-L1 more than 1%, CTRT if ineligible. If it is ineligible, then sequential. And if it is not progressing, you can give durvalumab as a consolidation therapy. It is not but FDA approved, but it is EMA approved for tumors PD-L1 more than 1%. Or if nothing is sequential or definitive chemo-RT cannot be given, you can give RT alone. So these are the situations where it is discussed very clearly in the ESMO guidelines. But as you know that when in clinical practice, you come across various situations where this won't come under the guidelines, but like you have to make a decision accordingly. So what do you do in incidental 3A, that is N2 or unforeseen N2?
If despite adequate medicinal staging procedure, N2 disease is documented intraoperatively, the surgery should be done. And it should be followed by adjuvant chemotherapy. And in case of complete resection, that is, it is R0 resection, you have to decide whether the patient R0 resection, adjuvant chemotherapy is given. And if it is R1 resection, you have to give port as well. And patients, and there are certain group of patients where you have staged as stage 1 or 2 in staging investigations. When you operate it, you find an incidental intraoperative N2. Actually, they have a good prognosis and they should also be considered for adjuvant chemotherapy. So these are various situations which you come across in clinical practice. And potentially resectable 3N2, that is a preoperative diagnosis. So we have already discussed, you have possible strategies, several options: induction chemo followed by surgery, induction chemo RT followed by surgery, or concurrent definitive chemo RT. And no recommendation can yet be made. However, an experienced MDT team is of paramount importance of any complex multimodality treatment strategies, because these are certain gray areas where you have to discuss these cases in the MDT, and you have to do what is best for the patient. If induction chemotherapy alone is given preoperatively, postoperative radiotherapy is not standard treatment and may be an option based on the critical evaluation of local relevance. That is what the MDT, that is why even in the ESMO guidelines, they have said that you have to discuss everything in the MDT, but there are certain things which are clear-cut where you can just follow whatever it is recommended. So definitive chemo RT versus sequential chemo RT has been investigated in RTOG 9410, which show that long-term survival benefit for cisplatin-based chemo RT, definitive chemo RT. And there is for a radiation oncologist, we come across pancreas tumors. So what do you do with potentially resectable superior sulcus tumors? Concurrent neoadjuvant, concurrent chemo RT induction followed by definitive surgery is the treatment of choice. And this same strategy can be even applied for potentially resectable T3 or T4, because in view of invasion or size, you can even give neoadjuvant chemo RT followed by surgery. But that too in highly selected cases, and that too in very experienced centers. And in both situations, usually they recommend that the surgery should be carried out within 4 weeks after the end of radiotherapy. I think that is mainly because in rectum you can actually wait up to 8 weeks, but here they have written that it has to be within 4 weeks. So I don't know whether there is any difference in the radiation reaction or whether the surgery would be more difficult if it is lung. And so it is recommended that it is done within 4 weeks. So unresectable N2 and 3B disease patients, definitely chemo RT is the treatment of choice. So I have already discussed, if it is not possible, sequential. Patients who are unfit, RT alone. And what about accelerated RT? That can be beneficial in the situation, and it has shown superior results. So what is the optimal chemotherapy to be given to stage 3 patients? Cisplatin or carboplatin in combination with RT. In the absence of contraindication, the optimal chemotherapy has to be combined with radiation is cisplatin, because cisplatin has the robust data. And there are no firm conclusions supporting single agent carboplatin as a radiation sensitizer. So for fit, inoperable stage 3, cisplatin-based chemo given concurrently to RT is recommended. According to level 1 evidence-based, cisplatin may be combined with etoposide, vinorelbine, or other vinca alkaloids. However, in some patients, based on specific comorbidities, other treatment modalities may be alternatively considered, that is cisplatin single agent, or carboplatin-based chemo RT, or sequential chemotherapy and RT, or even RT alone. So these are alternatives which can be proposed to patients with higher risk of infection, general or pulmonary complications. There are already randomized clinical trials showing the efficacy of single-agent cisplatin delivered concomitantly with that is weekly cisplatin. On the contrary, single-agent carboplatin has failed to improve survival when given concurrently with RT in prospective randomized trial. So most comparative studies of concurrent chemo RT versus sequential administration were cisplatin etoposide or cisplatin plus vinca alkaloid, that is typically cisplatin plus vinorelbine. So there are no comparative phase 3 trials using paclitaxel, but when delivered perioperatively, cisplatin-based combination are considered to be the treatment of choice. So what is the number of chemotherapy
cycles you should give. So in stage 3 disease, usually 2 to 4 cycles of concomitant chemotherapy should be delivered. So it is aiming at a cumulative dose of at least 300 milligram of meter square of cisplatin in the adjuvant setting. What's the optimal radiation regimen in concurrent chemo? 60 to 66 and 30 to 33 daily fractions. And majority of the clinical concurrent chemo has used this 60 to 66 gray cumulative RT doses in conventional daily fractions. So in RTOG 0617, they have actually randomized patients to high dose and the standard dose. So high dose they have given was 74 gray in 37 fractions, concurrent versus 60 gray in 30 fractions concurrently with weekly paclitaxel without cetuximab. So in that trial, they have found that there is no much difference between the high dose versus standard dose. So standard dose is just good enough to be given in the concurrent setting. And coming to accelerated radiotherapy, so JCO has published data in 2012 where a potential radiation schedule could be given in the delivery of 66 gray in 24 fractions. So they have shown that this has resulted in improved survival rate compared with so-called conventional radiation schedule. Apart from multiple fractions per day schedules, an accelerated high-dose regimen was investigated in, that was a phase 2 study, that was a SOCAR trial, that study also used 66 gray in 24 fractions. So these specific schedules actually represent valuable alternatives in patients where concurrent chemo protocols may not be possible. But the radiation, so these are, I have been discussing with about concurrent chemo RT, the concurrent, ideal concurrent chemo regimen, the number of doses, the ideal dose for RT. Now, what about RT in preoperative settings, as in superior cell carcinoma, where what dose has to be given? So standard preoperative radiation dose within the chemo RT protocol should be between 40 to 50 gray in conventional fractions, or 40 to 50 gray in accelerated fractions, BID. The majority of clinical trials have given preoperative chemo RT have used 40-50 cumulative doses in conventional fractionation of 1.8 to 2 gray per day. And in RTOGs, that was distance RTOG 0229. So would you give elective mediastinal lymph node irradiation in chemo RT? So you don't give. You treat only involved lymph nodes. So that is a no, big no. And like in small cell cancer, so is there any indication for PCI non-small cell cancer? No, there is no role. So to conclude, so what is the optimal sequencing? The optimal sequencing would be according to, so what we can gather from the standard guidelines across the world. So whether you want to follow the ESMO guidelines or the NCCN guidelines. So, and if the health economics is considered, so I think our part of the world, it would be easier to follow the ESMO guidelines, but there are guidelines like ESMO in NCCN guidelines to follow to decide upon the optimal sequencing. So the decision making would always be patient characteristics depending upon the patient factors, depending upon the tumor factors like pathological, molecular related factors, and because it is a very heterogeneous population from 3A to 3C, the pathways, that sequencing pathways is complex. And recently, not recently, like the past maybe 4 or 5 years, the incorporation of immuno and driver mutation has come to play in the treatment of locally advanced carcinoma lung. So the optimal sequencing should be considered with regard to all these factors which you have in place. So decide wisely. So I can only say that there are guidelines which you can follow, but there are anecdotal clinical case situation where you have to deviate from the normal pathways, and you have to discuss that in the MDT, and you have to do accordingly, which is what is best for the patient. Thank you.
Thank you, Roshni, for the exhaustive coverage. I'm reminded of the recent lung cancer CME which we had attended in Trivandrum, where we had a lot of discussion on these points. Are we practicing this accelerated hyperfractionation, even though it is not recommended?
No,
it has been recommended for a long time, but I don't think any of the radiation oncologists in our part of the state is following that. And what is the take-home message for this post-op RT in R1 and R2 resection? There is a lot of confusion in the
So
recommendations.
post-operative, if R1 resection, you have definite role for port. But if the tumor size is more than 4 centimeter node positive, you have to incorporate chemotherapy as well. In R2 resection, is there any role for, usually in the port, we usually give 45 to 50 gray. You can't go up to 60 gray. So is there any role for dose escalation in those cases in R2? No, we don't have robust data to say that. No, in R2, you can actually get away with RT and chemo in curative intent. I don't think so, sir. So if it is R2, then I think we are done. R1, we definitely have our say in
Yes,
RT as well as
but in
chemotherapy.
R1 and R2, we are being radiation oncologists, we are always tempted to
Yeah, we are
offer,
tempted.
offer post.
Yeah, R1 definitely not we are tempted, we have role. So we have port, and if adjuvant chemotherapy indications is very definite, so we have definitely role in R1 where if margin positive. But in R2 resection, you have to give local treatment because you have tumor, gross residual tumor left. So as a radiation oncologist, as has said, I have a very strong inclination to give RT, but I don't know like whether I would be able to give a dose more than 50 gray, considering the OAR. I am not sure about it because it is a post-op base, like we are treating, so I'm not sure about that. But still, I think we have to give local treatment. So what is the best local treatment available? It is only RT. So apart from systemic therapy, RT is given to which dose? So I'm not sure. So minimum 50 gray can be given. Maybe like we can boost. I don't know, sir.
Any questions from the audience? I think Anu will have something to say. He's looking after drafting.
My only question is in N2, post-op N2, in any situation will you give adjuvant RT or will we just observe?
Current data does not support. So we were very happy with the initial result, the collaborative group study, but now like with the robust evidence from POTSI and Langart, we don't have any say in it. Definitely like no, I wouldn't. But definitely in our two situation, like we, so you have to give some form of local treatment. So they have done a surgery. So unfortunately, so I think rather than going for maybe the surgeon, if it is discussed in MDT, no. So if the surgeons think that this might go in for an R2 resection, you always try induction. So now we have role for induction chemo, immuno, then restage and try to, if it is possible to do an R0 resection and at least an R1 resection. If it is not possible, like you can be devious because you think that this could be potentially resectable after an induction treatment, and then you operate. Then if it ends in R2 resection, then like what to do after that. So that is, and another scenario which we come across usually in our hospital is in superior sulcus. Okay, so you have decided that this patient has to potentially resectable. So I'm talking about potentially resectable patients. So those patients, so you are giving 40 to 50 gray in neoadjuvant setting, and you send this patient for surgery. And then they reassess this patient after 4 weeks, and then they say, oh, sorry, I don't think that this is resectable now. Then you are stuck. So for superior sulcus tumor, so that potentially resectable, you have to have continuous discussion with your surgeon, your radiologist, and you have to establish upfront that it is potentially resectable. Yeah.
Thank you, ma'am, for the detailed talk. Shall we move on to the next one?
Thank you, Dr. Roshni, for that excellent academic presentation highlighting sequencing strategies in locally advanced lung cancer. I request the chairpersons to hand over a token of appreciation to Dr. Roshni. Thank you, sir. I request the chairpersons to continue on the dais for the next 2 sessions as well. The next session is on challenging the no-fly zone, the non-surgical management of central and ultra-central lung cancers. I invite Dr. Arun Lal, Senior Consultant, Lisi Hospital for the same.
Good evening, everyone, and I will have around 25 slides in total. Hopefully, I will finish in around 20 minutes. Does all of us here do SBRT? I mean, can I have a show of hands of doing SBRT? Good enough. So, what I am trying to do over the next 20 minutes is, these are the things that we will be discussing. What is no-fly zone, and what is the concept of serial and parallel organ when it comes to SBRT? What is central and ultracentral? There are 4 data that we must briefly know. One is the NRG RTOG 0813 trial, which was published in 2019. Then the HILES trial, which created a lot of controversy in 2021. In 2024, we have the Sunset publication, and then we have a Yan meta-analysis of the central and ultracentral tumors, which was published in 2023. So this is the data that briefly that I will be mentioning. But if any of you want more info on the data, I will give you the PDF later. So without sleeping, if you sit through the entire session, I will be teaching you how to fly through the no-fly zone. So that is what we will be discussing today. So first and foremost, what we should understand is what is this whole idea, or where did this idea of no-fly zone came? So as you all know, Timmerman did the early initial works on SBRT, and in an initial series which was published in 2006, so what happened was that grade 3 to 5 dose limiting toxicity. So that is the endpoint for most of these central and ultracentral tumors. So grade 3 to 5 toxicity occurred in 14 patients out of 70. And when he compared that list, there was an 11-fold increased risk for patients whose tumors was closer to the trachea, the main bronchus, or the segmental bronchus. So this is from where Timmerman gave the first idea that there is something called as a no-fly zone. So the no-fly zone is the area of 2 centimeters around the proximal bronchial tree. So if the lesion is closer to the proximal bronchial tree, this is not an area for you to do radiation. So people who are routinely doing SBRT knows that the standard RTOG schedule for the peripheral tumors was 60 grain 3 fractions, or what we use the 54 grain 3 fractions. So basically that comes from the RTOG protocol, and in that RTOG protocol, this no-fly zone was excluded. So when Timmerman did this RTOG trial for peripheral lung tumors with 54 grain 3 fractions, the area that comes under this particular 2 centimeter zone was not at all included. So there was this definition of central, and ultracentral is a recent definition which came probably by the mid 2015-16 is the time when we see ultracentral in the literature. So central is defined as the lesion that is 2 centimeters around the PBT, whereas the most common definition for ultracentral is if the lesion is in contact with the trachea, the proximal bronchial tree, the esophagus, or the pulmonary vessels. So if the lesion, in the sense, if the PTV is directly in contact with these structures, this is called as an ultracentral. But if it is not in contact, but within the 2 centimeter radius, this is called as the central. Now, why are we discussing this? Why this entire concept of central and ultracentral? Any postgraduate, can they put your hands up? Don't worry, it's a simple question. It's not a complex question. PG, no? No PGs at all. Okay, what is a serial organ and a parallel organ? Just simple. It is there, so don't worry about big thing. Yes. So the single functional subunit, what we call will be the thing. So Dmax will be your constraint. So the classical example for a serial organ is Spinal cord, exactly. And what is a parallel organ? Subunits. So even if you damage a part of the organ, the rest of the area can take up that function. So a classical, this thing will have a volume definition. Like you can damage X percentage with X dose and still the organ will function. So a good example for a parallel organ is lung. So lung is always considered as a parallel organ. So the first and foremost, what is your name? Thank Abhishankar. Thanks, Abhishankar. So the first and foremost thing that happened with SBRT was that lung, which was considered as a parallel organ, should be considered as a serial organ when you are doing SBRT. It is simple logic. See, you have, say you are putting a damage to this particular part of the right main bronchus. It is essentially as good as damaging the entire right lung. Fine. There is no further R&D that goes. So what was once considered as a parallel organ, once you are going an extreme high dose per fraction, will act like a serial organ. So this was the conceptual difference that came from a conventional radiation series to an SBRT series when we started doing it. Now parallel to it, there is one another fundamental thing that you need to understand, because when you are giving 60 gray in 3 fractions, you are essentially giving a BED of 180 gray. Now for a tumor, it requires only a dose more than 100, a BD of more than 100 for a lung tumor. That is the classical Onisha data. So there is no real need for you to go up to 180 gray and fry this tumor. Any dose more than 100 will be enough. So subsequently, after the first RTOG publication, what was discussed was whether we can safely treat these central and ultracentral tumors, but instead of going for a 3-fraction regimen, can we go for slightly more protracted regimen? So this was the set of investigations that happened after the initial RTOG trial. So 60 gray in 3 fractions is giving 180 BED, and that is given only for the peripheral tumors. So you need a BED of only more than 100. So can you reduce the dose and then safely treat the central and ultracentral tumors? So the largest data comes from the RTOG 0813 trial from 43 centers in US and Canada. They recruited around 120 patients. It was a dose finding study. So they started at 10 gray per fraction, then went to 10.5 gray, then went to 11 gray, 11.5 gray, and their highest dose was 12 gray per fraction. So 60 gray in 5 fractions became the regimen that was used by the RTOG. And essentially the 2019 conclusion was that the grade 3 to 5 even, which are considered this the dose limiting toxicity, is only around 7.2%, which is acceptable in the sense this is the same dose limiting toxicity that you see in a peripheral lung tumor. So 60 gray in 5 fractions is a safe regimen. They had 4 treatment related deaths 1 year after the treatment, in the sense hemoptysis, pulmonary hemorrhage, all these issues were, but there in their total 160 patients, only 4 patients had a treatment-related mortality. So 60 gray in 5 fractions was an accepted regimen. This is the regimen that is most commonly used in US. Majority of these tumors were central more than ultracentral. So 60 gray in 5 fractions is more suited for a central tumor where the PTV is not in contact with the trachea, main bronchus or the pulmonary vessels. Now the reason why this is common in US is that in US you can bill an SBRT code only up to 5 fractions. If you are using a 6 fraction, 7 fraction or 8 fraction, you cannot bill it as SBRT in US. So US will go with this 50 to 60 gray in 5 fractions. But when you go to the rest of the world, they have seen a change. So there are 2 particular trials that we need to remember. First is called as the HILES trial and second is called the SUNSET trial. Now the HILES trial recruited 65 patients between 2011 and 16 from Sweden, Denmark, the Nordic trial. So the inclusion was that all these lesions can be either in touch with the proximal bronchial tree or within 1 centimeter of the proximal bronchial tree. This was the conclusion. Their prescription dose was 56 gray in 8 fractions. So it was 8 into 7 gray per fraction. But for practitioners of SBRT, try to remember, but they were prescribing to 67% isodose. So what actually happened was that when you are giving 56 gray, they were ready to accept up to 150% within their PTV. So this was the hot that they were ready to accept in the HILES trial. HILES became notorious. HILES was published in 2021. So when it was published in 2021, they had 15% treatment mortality. Now 15% treatment mortality is unacceptable. Even the surgeons cannot cause that. So we definitely cannot cause 15% mortality and get away with a schedule like that. Now, there are many criticism of HILUS. Basically, some of the criticisms are that one is that when you are using 67%, you are losing this game because that is not something that you can use for a central tumor. Second was that their PTV margin was pretty large, often up to 1.5 centimeter craniocaudally. So this is not something that you will routinely use for a SBRT plan in the modern setting. IV contrast was not mandated. So this again becomes a big problem because if we are not mandating the IV contrast, it is very difficult to contour the pulmonary vessels in for a ultracentral tumor. And ipsilateral lobar bronchus was never a part of their contouring. So their contouring stopped at trachea and the main bronchus, but the upper lobe, middle lobe, lower lobe bronchus, which is contoured as per the RTOG protocol, was never a part of the HILUS protocol. So there are many criticisms about the HILUS protocol, but eventually they have a very high toxicity of 15%. Now, it is not just the HILUS protocol. Many retrospective ultracentral data shows this 15% mortality and has significant death due to the bleeding events. This is the most common. Patient dying due to hemoptysis post SBRT within an year is very common with many of these retrospective series. Thankfully, Sunset came out with a slightly different data. So Sunset was published last year. This was again a dose-finding study of 30 patients from the 5 institutions in Canada. Now, they included what is the classical ultracentral tumor where the PTV overlaps the central bronchial tree, esophagus, pulmonary vein or pulmonary artery. So this is now the current accepted definition of an ultracentral tumor. The exclusion was that they excluded the patients with hilar nodes. I mean, with exclusively hilar nodes. If it's just a hilar node and a salvage SBRT, that was never a part of the Sunset trial. Also, they excluded lesions with clear endobronchial invasion. So they were taking a slightly safer set of patients. If you say their series, most common was that tumor was touching the central bronchial tree. Some had central bronchial tree plus pulmonary artery, central bronchial tree plus esophagus alone. So that was the series of patients that they had. With a median follow-up of 3 years, 6.7% experienced DLE. So that is not death. 6.7% is the grade 3 to grade 5 pulmonary toxicities. They had only one single death in the 30 patient group, and when they went back and checked the CT of that single patient, that patient had pre-existing ILD. Okay, so Sunset results are dramatically better than what we got from HILUS trial. So the dose here that was used was 60 gray in 8 fractions. So the other was 56 in 8. This was 60 in 8, but the difference is that 56 in 8 is to 67% isodose, whereas this was a classical 60 in 8, the way we usually prescribe. So why probably HILUS has a better results? It is limited to lung parenchymal tumors, excluding the nodes. They excluded the endobronchial tumors. They had motion management either with 4DCT or with breath hold. IV contrast was required for all the patients for whom there was no contraindication to IV contrast. And the full proximal bronchial tree was contoured as per the RTOG guideline. The ipsilateral lobar bronchus was not avoided the way HILUS did it trial. The hotspot was limited to 120%, and the PTV was limited to 5 millimeter. So there were multiple, how do I put it, better quality, better way of looking at the protocol from the Sunset results, and the Sunset result gave a reasonably good results. Now, just one more, or the next 3-4 slides are slightly crowded like this. So this is the largest meta-analysis that was published in 2023 by Yan et al. With around 1,100 patients. So we are talking about 30 patients and 60 patient series. So this had around 1,100 patients. The most common schedules were 50 gray in 5 fractions, 60 gray in 8 fractions, or 60 gray in 12 fractions. The 2-year local control is 89%, which is pretty good, which is as good as any SBRT series, be it peripheral or central. And the pooled incidence of death was 4%. Okay, this is still high, but this is only 4%. It is not 15%. So at least what you should be counseling your patient when you are giving them SBRT for a central and ultracentral tumor, or specifically for an ultracentral tumor, is that you must tell that there is a 5% chance of treatment related mortality. That is there. So it is never going to be 0. And I'll come to this again, but what they also told was patients who are on anticoagulation, so aspirin or clopidogrel, patients who has interstitial lung disease, patient who has endobronchial tumor, and patients who have concomitant targeted therapies, specifically bevacizumab, because many of these patients were metastatic patients who were on bevacizumab. So if these 4 criteria were there, the chances of bleeding actually goes up. So there is a guideline that comes from International Stereotactic Radiosurgery. So what they are trying to say is that dose of 60 grain 8 or 60 grain 15 is appropriate for central and ultracentral tumors. Second, consider limiting the proximal bronchial tree D max for a bed 3 of 133 to 150 gray. And if the patient is on antiplatelet or an anticoagulation, if you can discontinue that during the duration of radiation, that will be beneficial. If the patient is having any other targeted therapy, because we talk about bevacizumab, but many of them may be on some other anti-VEGF TKAs, so many of them may also have a bleeding risk. So if there is any such, if the patient is getting any such treatment, it may be better to avoid it. Endobronchial extension, if it is there is a significant risk of hemoptysis, and it may be better to bring the BPT dose to around 100 gray BED, not to 150 gray BED the way for other tumors. And if the patient has interstitial lung disease, be very clear to achieve this target of V20 less than 10%. So these are the set of guidelines that are given by ISRS for ultracentral tumors. So what we do in our center is that if at all whenever we are having an ultracentral tumors, we either take a 4-DCT or a DABH depending upon the patient's breath hold capacity, the number of lesions I have to treat. So many factors will come into my decision whether I am going for a breath hold or a 4D. IV contrast will be given for all these patients who can tolerate an IV contrast, so there is no confusion on that. If you are taking a 4D, then we will go for an ITV based plan. If it is a DABH, we will directly control the GTV. The PTV margin generally for ultracentral tumors is 3 mm axially and 5 mm craniocaudally. And in my practice, I don't differentiate between peripheral and central. To me, it is a very confusing. A patient comes into my OPD, I see the image, only after contouring the PBT and then putting the 2 centimeter, we will know whether this tumor is within this thing or outside this thing. So if I tell him 3 fractions and then I have to make it 5 fractions, it is confusing. So irrespective whether it is peripheral or central, I will be giving it 50 gray in 5 fractions, but I will be giving a HOT of 60 gray to the tumor when I am prescribing 50 gray. So that is how I will do for my peripheral and central tumors. If it is an ultracentral tumor, then I will be either going for a 60 gray in 8 fractions. In some of those patients, I have reduced the dose. Rather than going for 60 gray in 8, I have gone for 54 gray in 8. Or there are publications for 60 gray in 12. So for ultracentral tumors, this will be the strategy that we follow. Now these constraints are there in probably all your TPS. So depending upon the size of the tumor, there is a way to measure the R50% as well as the D2 centimeter. So this is the classical constraints for a lung this thing. The only other thing I wanted to highlight, at least for the PG's perspective, is the basic anatomy. So when you are contouring the PBT, you start at the trachea 2 centimeter above the carina. You contour the right and left main bronchus, and then you contour the right upper lobe bronchus, and the left side again we contour the left upper lobe bronchus as well as the left lingular bronchus. Then this area is called as the intermedius bronchus, and finally that gives the lower lobe bronchus of both sides. So this much should be contoured as a part of your proximal bronchial tree, and then given a 2 centimeter margin depending upon your protocol plan. Now, if you are using a 5 fraction Prejuin, again the standard constraints are available in the literature. There is no need to learn more about it, but it is 18 day less than 4 cc, so that is easy to follow. And Astro also gives the constraints for 10 fractions as well as 15 fractions. So that is the way we will understand. We can pick up one of these constraints, whether you are using a 60 grain 8 fractions or a 60 grain 15 fractions. So that is the presentation. Thank you.
Any questions from the audience?
Sir, I think it is historical because if you started using in your center, if you started with SRS, in SRS we will be giving prescription to a lower isodose, 60, especially if you started with gamma knife, you will be starting at 50%. Then if you have come to a Linac-based SRS, you would have come to 70%. So if you have brought that knowledge down, we will be using the same system. Advantage of prescribing to a lower isodose, if you are prescribing to 67%, is that your gradient will become much better. So your dose fall off will become better if you are prescribing to a higher isodose. But at the cost of extremely hot inside, and especially if you are doing for a central, a part of the trachea or the carina will come in your PTV. So that hot may be falling there. That is the probable reason.
This rescaling will be advantageous because we are giving a very high dose to the tumor center.
I do normalize in the sense if I am prescribing if I am using a DCA or a 3D plan for a lung, I normalize to 80% isodose. So that when I am prescribing 50 gray, I get 60 gray onto my tumor. So 80% normalization on a linear accelerator is routinely done in a peripheral tumor with a 3D or DCA. But for a central tumor, if you are using a rapid arc, most of the time we will be using a rapid arc or an IMRT for a central tumor because you will need some concavity which you will not get in a 3D or a DCA. So for an IMRT or rapid arc, rescaling down will not be a good strategy because eventually they will have to catch. I mean, the plan is coming with the ability to for the motion. I mean, the leaf motion, everything has to come accordingly. So after the final plan, if you rescale, the gantry may move faster or the leaves may not reach there. So there are multiple other issues that will come up. If you are using a rapid arc or an IMRT, rescaling, I mean, 2 to 3% is okay, but rescaling to 20% will not be a good strategy.
So thank you, Arundal, for the excellent presentation as usual. Any question, any comments from?
For the routine follow-up, sir, depends on the indication, sir. If it is a classical stage 1 lung, if that is the situation that we are talking about, the planned follow-up is PET scan after 3 months and then annual imaging with CXR in between. Most of the time when we get this sort of indications, this will be for a metastatic disease. It will never be for a primary ultracentral lung tumor. So which means their follow-up will be based on what systemic they are going to get and that entire things will be coming into the picture. I am not sure whether I have treated a primary ultracentral tumor. Most of the time, for some salivary gland sort of tumors, you may get it ultracentral, but not really for a lung cancer.
Are we concerned about the nodal failure rates, and is there any requirement for a EGFR blocker as an adjuvant in these settings?
Sir, actually, in all these series, they have recorded their local control as well as their regional failure rates. I did not go into that particular factor because the real concern at this point of time for central and ultracentral is the toxicity element. Only if you are able to safely deliver, then only the next thing comes. The regional failure rate is in the range of 20%. But the problem with the Western series, again, if you follow any SBRT Western series, the actual biopsy rate is only 40%. So 60% of the SBRT decisions that is being taken in the West is without a tissue diagnosis. So
how do they get these patients? Because we don't have a low-dose CT screening program. So these patients are recruited from the screening program, or how they are getting this? Any idea, or they are just randomly?
In all these prospective protocols, they have very clear definition. At least 2 CT scans 6 months apart, which is showing an increase in size or significant PET avidity, is their inclusion criteria for patients without biopsy. The social scenario, I'm not aware, sir. I don't know why.
I think we should move forward, sir.
Because of the time constraints, we are forced to wind up this session.
Thank you, Dr. Arun, for an insightful discussion. I request the chairpersons to hand over a memento to Dr. Arun. Thank you, sir. I request the chairpersons to continue on the dais for our last session. The session is on evolving treatment paradigm in the management of small cell carcinoma of lung. I request Dr. Swati Krishna, Assistant Professor, Medical College Hospital, Thrissur, to speak on the topic.
Ma'am, mouse pointer arrows for changing slides. Mouse for pointing and arrows.
Good afternoon, everyone. So today we'll be talking about the changing treatment paradigms in small cell lung cancer. So coming to the treatment of small cell lung cancer, when we look at the treatment, it has not changed. It had not changed since 1980s till 2019. So there were no new drugs, no new real updates were there, but it has all changed during the past 6 to 7 years, and we'll be talking a little about how and what has changed. So lung cancer, as you can see, it is by far the most lethal cancer worldwide. And when we talk about lung cancer, we mostly talk about non-small cell lung cancer, which constitute about 80% of newly diagnosed cases. But today we'll be talking about small cell lung cancer, which constitutes to around 15% of the newly diagnosed cases. And its epidemiology mirrors closely to its tobacco use. You can see there is a peak in the 1980s, which again is similar to that of the use of tobacco, and since then it has fallen and then has reached a plateau. So small cell lung cancer, it is a very aggressive neuroendocrine tumor with a propensity for early metastasis, and most of the patients present in advanced stage, with 70% of them presenting with extensive stage disease. And around 1/3 of the patients, they present with a limited stage disease, where we treat these patients with chemoradiotherapy with a curative intent. So first we'll be discussing about extensive stage small cell lung cancer. So the backbone of treatment for extensive stage small cell lung cancer has been chemotherapy since the 1980s. So what we give simple cisplatin and etoposide for 4 cycles, and we will give consolidation thoracic RT as well, and prophylactic cranial radiation. And what we see is this small cell lung cancer, it is a very chemosensitive tumor, at least in the beginning. That is, we get a major response in around 61% of patients with this chemotherapy, and a complete response in around 10% of the patients. And around 90% of the patients show some response to chemotherapy. But the problem is that the response that we get from chemotherapy is actually short-lived. That is, we get a transient response. So the time to progression is usually 4 months. That is, once we stop chemotherapy, the disease progresses rapidly, and within 4 months, the patient is having a progressive disease. And when we look at the data over the last 40 years, we can see the median survival was very dismal, within the range of 8 to 9 months. So we had to do something about this. And this scenario changed in 2018 with the introduction of immunotherapy. So as you all know, immunotherapy are drugs that helps our immune system to fight against cancer cells. And immunotherapy is more effective in tumors with high mutational burden, and small cell lung cancer, being a tumor with high mutational burden, was supposed to respond very nicely to immunotherapy. So these were the initial trials. This was one of the initial trials. Here we used an immunotherapy agent, nivolumab and ipilimumab, in previously treated patients with previously treated small cell lung cancer. So as we expected, we got a good response rate of around 10 to 20%. But what we see is the median progression-free survival was 1.4 months. And it's very difficult to get a number that's smaller than that. So we found out that immunotherapy actually worked, but it did not work as we had expected before. But contrary to the decrease, the progression-free survival, what we see is in patients who responded to immunotherapy, the response was long-lasting. So those patients who responded, they had a very good response even at 2 years. So this is unheard of in case of extensive stage small cell lung cancer before immunotherapy. So now we have a group of, what we have is majority of the patients didn't respond to immunotherapy, but for those patients who responded to immunotherapy, they had a very good response even at 2 years. So this was something something on which we could build upon. So we wanted to, so another important interesting finding in this Kaplan-Meier curve is that if you look at the curve, we can see that the combined arm, that is the arm which received both immunotherapy agents, it seemed to do a little better. But this was not a randomized trial, and we weren't sure whether this is just selection bias. So that's when we checked the randomized cohort, and we found out that ipilimumab, when added to nivolumab, did not give any benefit in case of extensive stage small cell lung cancer. And then we checked whether nivolumab is useful in case of in third line setting, that is in patients who have already received 2 previous cycles of treatment. And in third line setting, we found that the response rates were around 12%, and the median duration of response was 17.9 months, and the 12-month overall survival was 28.3. So based on these data, the FDA had granted approval for nivolumab in 2018, and since then it has been in use in US for extensive stage small cell lung cancer. But the approval was withdrawn. We'll come to that in a little while. So another agent, pembrolizumab, which was very similar to nivolumab. This was also tried, and it also showed an improvement in overall survival, and there was also a good response rate. And pembro was also given approval by the FDA in 2019. But the problem with giving a treatment in the third line is that we don't get much patients in third line. So in case of small cell lung cancer, as you can see, out of the 93 patients who received first line chemotherapy, only 22% of the patients were able to receive the third line therapy. But we know almost all of these patients might have progressed in due course. So what happened? The patients might be very weak to receive a third line drug, or the disease might be progressed, and we wouldn't have been able to give the treatment. So we wanted to move this drug upwards. We wanted to move immunotherapy upwards. So this was a trial which tried to give immunotherapy, that is nivolumab, in second line setting. So here we compared nivolumab with topotecan, which is an old chemotherapy agent. It's very myelotoxic, but again, immunotherapy was not able to, succeed. Like immunotherapy was not better than topotecan. So there was no difference in overall survival, and hence immunotherapy was not given second line. And then we tried to give it in maintenance setting. Again, there was no survival when compared with placebo. But we know that the best opportunity for to produce an impact is basically when we give the drug in first line setting. So what if we give immunotherapy in the first line setting along with chemotherapy? And at this point of time, we knew that atezolizumab, another immunotherapy agent, could be combined safely with chemotherapy based on phase 1 studies in non-small cell lung cancer. So then came the landmark trial, IMpower 133. And in this trial, this was a double-blinded, placebo-controlled phase 3 trial which evaluated atezolizumab plus carboplatin and etoposide in patients with extensive stage small cell lung cancer who had not previously received any treatment. So what did we see? We saw that in the first line setting, along with chemotherapy, immunotherapy had improved the progression-free survival as well as overall survival. And based on this, it was given approval in 2019, and since then it has been used as in the first line setting all over the world. Now, another agent, since studies on atezolizumab and the other trials which included immunotherapy had been conducted, and this was in 2000. This came after 1 year, that is in 2019. This is a Caspian trial which used durvalumab plus platinum etoposide chemotherapy in first line setting. And the same result, that is immunotherapy improved the progression-free survival as well as the overall survival. So these are the other trials which evaluated immunotherapy in the first line setting along with chemotherapy, and we can see there was a very good improvement in overall 1 year overall survival in all these trials. But what we wanted to know was that whether this improvement in initial improvement in overall survival translated to a long-term survival. So then came the updated results of Caspian and the updated results of usage of atezolizumab. So this in Caspian trial and in both these trials, we can see that there was an improvement in progression-free survival as well as overall survival over the 5 years, over the 3 years, and here over the 5 years. Another important thing and another interesting thing to note is that, as you can see, the graph tends to plateau after 2 or 3 years. So that means we might be looking at a similar overall survival even after 10 years. So maybe we might be looking at a patient who might survive at 10 years with extensive stage small cell lung cancer. But even though immunotherapy worked in a subset of patients and it worked very well in that subset, there was a large group of patients who did not benefit much from immunotherapy. So we had to improve upon that. That's when we introduced another drug called lurbinectedin. And this lurbinectedin it is a marine-derived compound. So there is this company in Spain which is called PharmaMar. So what this company focuses on is to find out natural substances that might help us fight against cancer. So what they do is they dive deep into the sea. They go there, they find substances that they think might help. They bring it up to the lab and they see whether any of these compounds might work. So what they found out was that this agent, this lurbinectedin, did work. And in phase 2 trial, this lurbinectedin has shown some 35% in response rate in small cell lung cancer. So based on this setting and based on need, an accelerated approval was given in 2020, and since then it has been on use. So how does this lurbinectedin works? So lurbinectedin, there are different mechanisms of action. First one is it inhibits oncogenic transcription. Then another mechanism is that it induces DNA double-strand breaks. And another important thing is that it helps to make some changes in the tumor microenvironment. So we thought whether we wondered whether this would be we could combine this with immunotherapy. So with immunotherapy also, this lurbinectedin had shown some response rates. And then we moved it up. We wanted to see whether what it will do in the first line setting. So this is IM40 trial. In IM40 trial, what we did was we gave lurbinectedin in the maintenance setting after chemoimmunotherapy. That is, we would give for a patient with extensive stage small cell lung cancer, we would give chemoimmunotherapy initially, and then we would keep them on maintenance with lurbinectedin and atezolizumab. So what we found out was that there was an improvement in progression-free survival as well as overall survival. So now, in case of extensive stage small cell lung cancer, we have chemoimmunotherapy in the first line setting with maintenance immunotherapy along with maintenance lurbinectedin. Now coming to limited stage disease, the earlier practice was to give a concurrent chemoradiotherapy with cisplatin etoposide, twice daily thoracic RT, and PCI in responders. And the 5-year overall survival was around 10 to 15%. And immunotherapy was again introduced in this setting also. So this is the Adriatic trial which introduced the durvalumab in maintenance setting in limited stage small cell lung cancer. And as you can see, in limited stage lung cancer with the maintenance, the durvalumab maintenance increased the overall survival as well as progression-free survival. So next question was, what if we give immunotherapy along with chemoradiotherapy? So this was a trial which tried to introduce immunotherapy early on along with radiotherapy and then in the maintenance setting. But as you can see, there was no improvement in, there was no difference in overall survival or progression-free survival. Maybe that might be because of the interactions between immunotherapy and radiation. So right now, what are our current options for extensive stage small cell lung cancer? In the first line, we have chemotherapy, cisplatin, etoposide, and atezolizumab, or cisplatin, etoposide plus durvalumab, and PCI and thoracic RT. So those things are in question right now. And then in the maintenance setting, we have atezolizumab and lurbinectedin. And for limited stage small cell lung cancer, in the first line setting, we have chemoradiotherapy, and then in the maintenance setting, we have durvalumab. And this is where we are currently at. So what are we excited about moving forward? The first one is radioligand therapy with lutetium. This has been approved by the FDA, and it has been in use for GI cancers, GI neuroendocrine tumors, and it might be, there are studies that are ongoing in which they are testing whether this radioligand therapy might be useful in small cell lung cancer. Another newer treatment option is bispecific T-cell engagers. So these are biosynthetic molecules. They can bind to DLL3 in the tumor cells as well as CD3 in the T cells, and they can bring both of them together and thus induce the tumor cell apoptosis. Another important, another newer development is ADC or ADCs. So you might be knowing about that. And then another thing that we are researching on is to find out any special biomarkers that might give us some idea which of these tumors might respond to immunotherapy or which of this might have a good prognosis. There has been we have found out some correlation between favorable response and expression of certain transcriptional regulators, but these studies are in the initial phase and this cannot be used to decide upon treatment currently. So that's about small cell lung cancer up to now. And there are a few questions that we should be asking ourselves as radiation oncologists. The first one is the role of thoracic RT in extensive stage small cell lung cancer treated with chemoimmunotherapy. So as you know, most of the trials that validated thoracic RT was in the pre-immunotherapy era, and we are not so sure whether this thoracic RT is needed in this immunotherapy era. Another question is regarding the role of PCI. So whether MRI surveillance is enough in patients who have undergone chemoimmunotherapy. And luckily there have been a few studies that are ongoing regarding, they are investigating regarding the role of PCI in immunotherapy. Thank you.
We can allow only one question from the audience because of the positive time. Any questions? Okay, if there are no more questions, we'll wind up. Thank you for the excellent presentation. The results of a small cell carcinoma still remains very dismal in spite of all these innovations. Just hope that there will be some light at the end of the tunnel in the future.
Thank you very much, Dr. Swati. I request the chairpersons to hand over a memento to Dr. Swati. I now request Dr. Shaimalada, retired professor, Medical College, Thrissur, to hand over mementos to our esteemed chairpersons. Thank you, everyone. With this, we conclude today's scientific sessions in Hall B. The inaugural function will take place now in Hall A, and tomorrow the sessions in Hall B will start at 10:30 a.m.